Okay. Good morning. I'm calling this public roundtable to order. Today is Thursday, January 22nd, 2026. The time is 9:32 a.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Holding this roundtable today on St. Elizabeth's Hospital, the operational and safety issues. St. Elizabeth's Hospital is the district's only publicly operated psychiatric hospital. For many patients and families, it represents the final safety net in moments of acute crisis. For the dedicated staff who work there, it should be a workplace that is safe, functional, and properly resourced. Unfortunately, what this committee has heard over the past few years from frontline workers, unions, and advocates suggests that this is generally not the case. The committee's review of materials provided by the Department of Behavioral Health in advance of this roundtable reinforces many of these concerns. Staffing data reflects significant vacancies in frontline and supervisory positions. Unit-level staffing reports show frequent reliance on unstable coverage, including staff who are unavailable due to injury or reassignment. Maintenance logs and capital project updates show delays in addressing safety-related maintenance and infrastructure needs, even when funding has been approved. Staff survey responses describe low morale, insufficient support following assault and injuries, and a disconnect between policies on paper and conditions experienced on site. Taken together, these are not isolated or abstract policy issues. They are operational failures with real consequences for patient care, staff safety, and the hospital's ability to function as a therapeutic environment. They also raise questions about accountability, communication, and whether existing oversight mechanisms are sufficient to identify and correct problems before they escalate. The purpose of today's roundtable is not to assign blame, but rather to understand how we arrived here and what steps we are taking to correct in the future. I'm focused on solutions, clear timelines, and accountability, and on ensuring that St. Elizabeth's Hospital can meet its mission to safely care for patients while protecting the workforce that serves them. I'm now going to turn to my newest colleague, at-large Councilmember Donnie Crawford, if she has an opening statement.
Thank you, Chairperson Henderson, and good morning, everyone. This is my first hearing as a council member, and I appreciate the opportunity to begin that work by focusing on the oversight of St. Elizabeth's Hospital, an institution that plays a critical role in our behavioral health system and in the lives of some of the district's most vulnerable residents. The testimony that we will hear today raises serious concerns about operational breakdowns at the hospital, including persistent staffing shortages, disorganization, and facility challenges that delay care, limit access to services, and impede recovery. We are also hearing troubling evidence of patient safety failures, high use of restraint and seclusion, unmet basic needs, inappropriate patient placement, and prolonged hospitalizations driven not by clinical necessity, but by gaps in housing and discharge options. Today's hearing is about accountability, but it is also about solutions, how we support staff, improve patient care, and ensure St. Elizabeth's can meet its mission. I look forward to working with my colleagues and hearing from witnesses about concrete steps forward. Thank you.
Thank you. Okay, as other council members join us, we'll certainly turn to them. Right now, we're going to turn to our public witnesses. So all of our witnesses will have 3 minutes to testify. You are welcome to submit longer written testimony. 3 minutes doesn't mean that we don't care about what you have to say, but we do have a lot of people here who we want to hear from this morning. And given that we are actually at the start of performance oversight season, we've got some time constraints. So I'll give you a nudge once your time inspires. For those who are in the room, there's a clock right there on the table. And then we'll talk about the virtual once we get there. All right, so I have 4 seats here. Nancy Boyd. Okay. Serena Childris. Daryl Stewart. And Bridget Bennett. Great. Okay, Ms. Boyd, when you're ready, just hit the mic. There you go.
Okay, good morning. My name is Nancy Boyd. I'm a registered nurse educator at St. Elizabeth's Hospital. I also serve as the DCNA DBH Chair President, representing over 2,200 RNs and licensed healthcare professionals in the District of Columbia. Today, I want to address the serious issues facing our hospital leadership. Last week, I don't know if you're aware, but me and my colleague, Local 2095, President Serena Childris, met with Deputy Mayor Wayne Turnage to discuss our operational concerns, a conversation many of you might hear echoed in testimonies today. Present at that meeting were 8 of our top DC management leaders and just us 3 labor representatives. We found ourselves listening once again to the same speech from our CEO, Mr. Mark Chastain. For 3 years, we've heard about minimal improvements and only seen things regarding glucometers and overhead system and the furniture project. Yet these initiatives have dragged on for multiple years with little to show for it. Management often shifts the blame to the billion-dollar budget cuts, the pandemic, and various other crises that occurred at the hospital. But despite numerous meetings and discussions, there has been no real action or willingness to shift the culture at St. Elizabeth's Hospital. It is crucial to state that after 9 years of this leadership, our faith in their ability to create a safe operational facility is non-existent. The issues we face, multiple immediate jeopardies with the Department of Health, increased staff and patient assaults, and a broken infrastructure have only worsened. These problems are not new. They've been developing over a decade, and we can no longer sit quietly in meetings. Our members are demanding action with clear deadlines and tangible goals. The data on violence, staffing, and absenteeism is alarming, and yet executive leadership shows a disheartening lack of commitment to genuinely improve those conditions. The burden now rests on us, the dedicated staff. Instead of whispering our frustrations in break rooms, we stand united to advocate for those who fear retribution for voicing their concerns. These long-standing issues cannot be attributed to recent crises. They reflect a deep and troubling mismanagement of resources and a lack of accountability. While our leadership claims to value the input from labor, it often leads to division among the staff rather than constructive dialogue. We need leaders who are serious about culture change and not those sustaining a toxic environment. We are trapped in a hospital falling behind in technology and practices. It's time for a fresh perspective and innovative solutions. It is evident that our management lacks the urgency to elevate standards and compete with other facilities, which is not only disappointing but demoralizing for those of us who work here. Today, we stand united, ready to voice our concerns and seek the profound change we desperately need. It's time for some serious action. Thank you for allowing me to testify today. I'm done. Thank you.
Thank you. Ms. Childris.
Good morning, everyone. Ms. Henderson.
Can't hear me.
Ms. Henderson, thank you for allowing us to talk again. Last time we was here, we addressed a lot of issues and concerns that we have, and it's still the same. Like Ms. Boyd said, exactly what she stipulated is still going on. The staffing is getting lower. Staffing is getting lower. The units are getting more hectic. We can't get any assistance from the person that, we can't get no assistance from the chief of nursing to address some of the issues that's going on the units. We have been in many meetings, still going on meetings. And like Ms. Boyd said, we just met Mr. Turnage, and he wants to set up to do something like to try to assist administration and getting the work done. Well, we're talking about 4 years of work, and the building is falling apart. There's holes in the ceilings that have been there for years. There are holes in the dining room where the patients eat at. That's water. When it rains, it comes in and they're sitting at the desk while water's falling on, and we have to remove them. We have also things broken up on the units that they're used for weapons. I mean, whatever they feel they have done, they've done it to their limit. They didn't do it to a hospital-wide to make safety in a hospital, to provide the care that the patients need in a hospital, or the staffing. So we're working every day. The overtime is ridiculous. And it's even more ridiculous now because, we're getting people, we're hiring people. But the people come there and they leave because of the morale, because of the unsafe work environments, because of the hostile work environments. So we're asking for change today, if not change, a resolution to help administration get that building in order. Thank you for listening.
Thank you. Mr. Stewart.
Good morning. Good morning, Councilman Henderson. Thank you for this opportunity. Good morning, members of the committee. My name is Daryl Stewart. I'm a board-certified adult gerontology primary care nurse practitioner, a former employee of St. Elizabeth Hospital, and a former vice president of the District of Columbia Nurses Association. As you may recall, I testified before this council in May 30th, 2025. Regrettably, I'm here again to report that the conditions I described at that time remain unchanged and in some respects have worsened. Today, you will hear directly from frontline staff who continue to experience unsafe and deeply concerning working conditions. In contrast, the committee has received responses to a 30-point questionnaire from the current St. Elizabeth Hospital administration that lack concrete, actionable plans and reflect ongoing leadership deficiencies. These concerns are further corroborated by employee survey data demonstrating significant institutional decline within this more than 150-year-old hospital. The patient care environment remains unsafe. There continues to be a 5-to-1 ratio of pretrial admissions from the District of Columbia Central Detention Facility compared to civil admissions from the general population. This imbalance has contributed to escalating incidents of violence, both towards patients and staff, without any comprehensive or effective plan in place to mitigate these risks. Chronic understaffing persists among frontline workers, including nurses and mental health technicians, who are central to hospital operations. Despite this, administrative priorities continue to emphasize high compensation for senior leadership without demonstrable improvements in staffing, safety, or care delivery. This misalignment has further strained an already untenable situation. Shortages of medical supplies and basic hygiene products for patients also continue. Non-nursing staff has at times personally purchased hygiene items for patients, though many are hesitant to testify out of fear of retaliation. These accounts stand in contrast to assurances provided by hospital administration. During my testimony last year, I raised concerns about patients not receiving eyeglasses. Since that time, the situation has deteriorated further as the hospital no longer has an eye care provider. And when I mean eye care provider, I mean a specialist. Prescription eyeglasses is what I'm speaking of, not over-the-counter eyeglasses. Additionally, patients are not being evaluated monthly as required by hospital policy in both medical and psychiatric services. There are ongoing concerns regarding inaccurate or falsified documentation of patient care, including instances of copied or plagiarized provided notes submitted for billing and court purposes. These issues reflect systemic failures in oversight and accountability, despite assurances previously given by Dr. Basron and Mr. Chastain that all patient service needs are being met and that St. Elizabeth Hospital was a top priority. Finally, I want to address fiscal management. 8 months into the current fiscal year, we continue to hear from Mr. Chastain that there are insufficient funds to address these persistent deficiencies. I attended budget meetings last year in which this committee questioned why the hospital's budget failed to reflect the needs identified through testimony. At the time, the administration cited deficiency in streamlining efforts, but based on continued reports and observed conditions, I believe there are serious concerns regarding financial mismanagement and potential Medicaid billing irregularities. And these concerns warrant a comprehensive top-to-bottom forensic accounting audit, which I believe will reveal underlying causes of the hospital's ongoing failures. Thank you for your time and for your continued attention to these critical issues.
Thank you. Ms. Bennett,
Hi, good morning.
good morning.
I would like to talk about again, environmental safety and the structure of the hospital in a more direct way. There are many things we need to work with daily has been noted to be deemed unsafe. For the individuals in care and staff, we have broken furniture, broken doors that are used as weapons. Doors are poorly built and easily to be kicked in. Locks are very weak on the units. The doors are made of plexiglass. And on a number of occasions, individuals in care have been known to kick in the doors to attack staff as well as other individuals who we try to move to a safe area. ICCs who are confined to wheelchairs are on the upper level, upper units. When there was a kitchen fire, we had an individual who absolutely refused to be moved, who was confined to a wheelchair. Staff had to stay back to ensure this, person's safety if things get worse. That is just unacceptable. It's unacceptable. We've asked prior to that for these individuals to be moved to a lower level. But due to how hospital is managed, they allow middle management to decide if they're going to take an individual in care to their unit versus the need of the patients. Those are just some of the things that I would like to bring up. On the far as water, many of the units don't have hot water. The intensive side does not have heat. Staff and patients are both getting sick. And these things have been questioned and asked, but we've never got a clear answer to where these things are fixed. On that same side of the building, during the summertime, there's no air conditioner. And again, individuals are getting sick. And you know, when patients are sick, hot, they tend to be more irritable. So we just want these things addressed properly without, you know, the hesitation and the runaround. Thank you so much.
Thank you. Ashley, we do put 6 minutes on. I'm trying to keep myself honest here. Thank you all for being here and for testifying. It feels a little deja vu. And I would just want to say for folks, so you know, we had the hearing in May. Lots of you testified at that time. And I met with Deputy Mayor Turnage heading into the budget. It was like, hey, what's going on? We need to talk about what's going on at St. Elizabeth's. I had breakfast with the city administrator and I talked to him specifically about St. Elizabeth's. That was the crux of why we met. And then I met with the mayor. And so I don't want you to think that your concerns went unheard. I took it all the way to the top because I felt like we weren't getting the action that was necessary, but also some of these require financial investment to address some of the issues, whether it be the contract for psychologists, where I think there's like a 26% vacancy in terms of that requires action from EOM to do something with that. Whether it's addressing some of the capital improvement issues, that is a financial piece as well. And so when I got the letter, multiple letters of the grievances that the unions had filed, I was like, I thought that we were heading in a right direction, but you guys were like, no, the issues are still going. I met with Dr. Basron, I met with Mr. Chastain, and at the end of that meeting, I said, so we're gonna do a public hearing. And I felt it was important to do this hearing separate and apart from the traditional performance oversight, because often there's a lot of other stuff that Department of Behavioral Health does. And sometimes we are guilty of focusing on just the main part of the agency without focusing on the hospital part. And so there needed to be a separate conversation. There are lots of different things in sort of the thread of all of what you guys are bringing up. We did send some pre-hearing questions, which we got the responses back and to us. So for instance, I asked about work orders, received a document about open work orders. And I noted that in the comment part of the work order, I was like, why is this reading like an email? Why is everybody saying good morning or good afternoon, so-and-so, as opposed to a system where it is a thing? So I just want to get some clarification. Are you sending, when you have a work order request, are you just sending an email to an inbox, or is there an actual form of some sort? Oh, sorry. I know I hear from the crowd, but people at home can't hear. So somebody at the table is gonna have to reply.
It's an email. It's a joint email with multiple people on it.
Okay. I also noted that some of you, or some of the comments, it was like, I'm emailing for the third time and this has not been resolved. Is there any follow-up when you all send a thing about a work order?
Well, when we do the work order, most of the time it takes months to even do a follow-up. And then we asked the question like last week, like during the meeting with Mr. Chastain. And he wasn't there, but we asked Mr. Singh, which is the finance officer, the chief finance officer, who's responsible for making sure that this stuff that needs to be done in the hospital is done. And I was told the unit managers, I said, it's a facility issue. The unit managers works on the units. And it goes through, everybody knows. And it does not get done until months later or after we leave here like we did last time.
Well, it was so interesting because I noted to my staff, well, first off, there are a lot of things of locks multiple times. Lock's not working. Lock's not working. Oh, this one. I'm following up for a third time regarding a light that is out in a bathroom. The issue has been previously reported and not resolved. Interestingly enough, on what they sent to us, they don't give us the date of when the request was sent. It only says estimated start and whether or not it was finished. So I have no idea if you all requested this in September. And then the estimated start happens to be December 28th, 2025. Let me ask this because I've gotten multiple responses on this. In the org chart, as you know it, for the union leaders, who is responsible for maintenance? Who does that fall under in terms of the executive leadership of the hospital?
So I'm glad you asked that question because we do have a speaker here, Mr. Larry Leonard, that does deal with that. And he is here to explain all of that.
Oh, he'll be on the next
He'll be in
panel.
the next panel.
Okay. We deal with work orders for schools. It's a little bit different, right? Because I got DGS, so I have multiple agencies that I can deal with, but I also know that they have contractors. But I also know the work order system for schools is a very comprehensive system that we actually have access to, that I can go in, the Committee on Facilities can go in and see what was submitted, where is it in progress, and then they can attach a picture when they're finished, because, you know, trust but verify. That doesn't seem to be what this hospital has. Okay.
No, ma'am.
I'm over my time. Councilmember Crawford?
Thank you. I was not a member at the last hearing in May, so some of this is new for me. Ms. Childris, I wanted to ask, you mentioned that the overtime has increased at the hospital, right?
Yes, ma'am.
So in the responses to the committee, the Department of Behavioral Health said that they do not, St. Elizabeth's does not mandate overtime and double shifts. Mandatory overtime is implemented during emergencies such as inclement weather in compliance with collective bargaining agreements. Is it your understanding that overtime is mandatory?
Can't leave. You can't leave. Well, let me just say this. It is, we have to wait for relief. We can't leave. You know, we'd be abandoning the patients.
Okay.
So when we have no staff or somebody calls out or whatever, we have to make sure we're there. We can't leave.
Okay.
So yes, and in so many words, yeah, we're like, you can't go nowhere.
Okay.
So it's kind of like a mandate
Mm-hmm.
if you can't move.
Mm-hmm.
And sometimes people, you know, they leave and then they think they add people on the schedule that's not said, that didn't say they was going to work. It's a mess. So you become consumed working and then oh, I don't have this, I don't have that. But you say you hiring people. No.
Does
doesn't
anyone
make
else also want to weigh in on the overtime piece before I move to the next question? Okay, and then also, Ms. Children's, you mentioned the staffing being lower. From your perspective, which staffing gaps, is it psychologists, psychiatric nurses, behavioral health technicians, security, that is most driving care and the shortage?
The whole entire department. Every
Okay.
department in that facility that takes care of individuals in care
Mm-hmm.
is low. Psychology, I don't even know if they have, how many psychologists, one of them was supposed to be, but anyway, it's low. I don't think we have a full staff in any department besides administration.
That's it. That's it for my first round.
Okay.
Thank you.
Thank you, Councilmember Crawford. I just want to follow up. Ms. Bennett, you talked about units not having heat. Can you say more about that, please? Because we're about to hit a significant weather event, so that's kind of critical.
Yes, several of the members have come, and we have two sides. We have the intensive side and we have the transition side. The intensive side, for good over a year, have been complaining about no air conditioning during the summer months and no heat. People are sitting in the hallways on one-on-ones and there's no heat. They're sitting there with coat, their outdoor coats on the unit.
You said on the intensive side.
In the intensive side.
Okay. Mr. Stewart, you covered a lot in your 3 minutes. First, I want to give you kudos for how you crafted your testimony. But you also made some, I think, pretty serious allegations around plagiarized provider notes and Medicaid billing irregularities.
Yes, that's another venue that's being explored outside of this forum. But yes, it's my belief. Allegedly.
Okay.
It's my belief.
That's enough for me to refer that to the
Okay.
Inspector General. Medicaid billing fraud is out of our wheelhouse. That's an Inspector General function. But the plagiarized provider notes is pretty intense in that regard. Also, let's go back, because I do remember us talking about glasses. There's no optometrist on staff any longer?
Ophthalmologist.
Ophthalmologist?
Yeah. No.
Okay.
The contract ended in September 30th of 2025.
Yeah.
And I was told personally by the ophthalmologist that she would not be returning. And as I know of now, they have not replaced that person. The ophthalmologist was responsible for doing comprehensive eye exams for prescription eyeglasses. So there are some patients that needed prescription eyeglasses, not just readers.
Yeah.
And of course, we talked about this last time about how important that is when it comes to competency and restoration.
Yeah.
Being able to participate. So if you don't have an ophthalmologist who actually can do a comprehensive exam and make a prescription for prescription eyeglasses, the agency cannot provide those eyeglasses. Now, what they may tell you is that they have readers, and they may tell you, I've gotten information that
I'm wearing contacts, so I feel you. Readers are very different.
I've gotten information that people in another department are doing eye exams, particularly I think the PDS department may be doing eye
The
exams.
PDS.
That's PBS, behavioral health support, may be doing eye exams, and then they may give them some readers to use, but that's not a comprehensive, they're not certified to do, licensed to do eye exams and then make a prescription and then, take care of that issue for a patient.
Okay. I'll follow up. I'll follow up on that. How do you participate in a competency exam if you can't read what is being presented to you? Okay. Thank you. Thank you to this panel of witnesses. We're going to go to the next panel. I'm going to apologize in advance for perhaps not getting someone's name exactly correct, but I'm going to do my best. All right. Salamatu Kadahar. All right. Funmilayo Olugbemi. Doing my best. All right. Zena Hunter. Sarah. Okay. Larry Leonard. All right. And Hans Thomas. All right. Ms. Kadahar, are you ready? If I said that correct, if I didn't say right, please print it. Okay.
Okay. Good morning. My name is Salamatu Kadahar, and I am here to formally address the ongoing workplace issue at St. Elizabeth Hospital that significantly impacts staff safety, compensation, moral, and quality of care we provide. I am a registered nurse, and I have been employed at St. Elizabeth Hospital since 2011. And this concern have persisted for too long, and immediate corrective action is necessary. Firstly, I would like to highlight the issue of hazard pay. Staff at St. Elizabeth Hospital are continually exposed to hazardous working conditions, including chronic understaffing, high acuity patient assignment. We face frequent behavior emergencies and increased risk of injury. Despite this risk, management refused to sit at the table and negotiate the need for hazard pay. It is essential that we appropriately compensate for working in such unsafe environment. Next, chronic understaffing across our unit poses a serious threat. We are frequently assigned unsafe patient ratio, and we are exposed to cover multiple roles, while managing increased patient acuity without adequate support. This condition not only put our patient at risk, but also endanger staff, contributing to burnout and high turnover. We urgently need to address staffing level to ensure both safety and quality of care. Additionally, I want to bring attention to the issue of overtime and differential pay. Due to ongoing staffing shortages, staffing members often feel pressure to work overtime. However, we face inconsistency in receiving appropriate overtime pay and shift differentials for night, weekend, and holidays. Proper compensation for work beyond scheduled hours is not only a matter of fairness, but a necessity in line with labor standard and hospital policy. Finally, I want to address the time clock procedure that we currently have in place. Staff are required to clock in and out at their home unit rather than the assigned unit. This practice leads to unpaid time spent traveling between units, which does not accurately reflect our actual work hours. We should be allowed to clock in and out at our assigned work unit to ensure fairness and precise timekeeping. In conclusion, the issue we are facing at St. Elizabeth Hospital, lack of hazard pay, unsafe staffing levels, inconsistent overtime, and differential compensation and improper time clock procedure require immediate attention. This problem negatively affects our well-being, patient safety, and the hospital overall functioning. I respectfully urge a thorough review and prompt a corrective action to ensure fair treatment on safe working conditions and compliance with labor standard. Thank you for allowing me to share my testimony today.
Thank you. Ms. Olugbemi?
Good morning, everyone.
Oh, you just gotta turn your mic on. There you go.
Oh, okay. Good morning, everyone. My name is Funmilayo Olugbemi. I am a registered nurse and a team leader at St. Elizabeth Hospital on Unit 1A Allison House. I am here to address critical staffing, safety, and equipment concern on Unit 1A Allison House. It is a geriatric, medical, and forensic psychiatric unit. Unit 1A serves 26 highly vulnerable patients. It has a capacity of 27 patients. One is in rehab right now. They are mostly age 60 and above. Many with severe psychiatric conditions combined with complex medical needs, including wound care, choking risk, seizure, falls, and total care dependency. Despite this complexity, the unit has been without a manager for over a year, and staffing consistently falls below the nursing quote-unquote department matrix. The matrix requires 8 staff on the day shift and 7 on the evening shift and night shift. Yet these levels are rarely met. Safe care on the day shift alone requires at least 4 RNs and 4 BHT, meaning behavioral health technicians. But this almost never occurs. Medication administration is extremely time-consuming on 1A because of the type of clientele that we have. Medication must be crushed. They must be delivered where our individual in care, where they sit. And often we need to cajole them. It takes, one patient could take up to like 20 to 30 minutes to administer the medication because we have to crush and do all sorts. So we need RNs for early morning finger stick to check the blood sugar because, of their medical issues. For medication administration and for dining room supervision. When staff must escort patients to outside appointment, there is no adjustment to staffing, leaving the unit dangerously short. Evening and night shift face the same challenges. Night staff begin total activities of daily living as early as 5 a.m. Many patients require 2 to 3 staff members at a time due to incontinence, immobility, and combativeness. Floating staff and overtime are used to fill these gaps when we're short. But this does not ensure safety because it leads to burnout and low morale, and they don't really know what we do on 1A, taking care of the geriatrics. Absenteeism further worsened the problem. BAT callouts are frequent and unpredictable. A shift schedule for 8 or 9 staff may start, at the beginning, may only wind up having 4 or 5 staff with no accountability. Callouts have become normalized, disproportionately burdening staff who consistently report to work. Unfortunately, time and attendance is an epidemic of which hospital management is already aware of and not taken seriously, and there's no accountability. We have seen no interventions in management's approach to proactively plan staffing around these mass callouts. Recruitment is another concern. Unit 1A needs certified nurse assistant due to the high level of medical care required. We must ask, are we marketing effectively? Are we partnering with CNA and nursing schools and attracting candidates with the right skill set? Finally, equipment and safety issues remain unresolved.
You're about a minute over your time, so.
Oh,
we can
sorry.
just-
Okay, we were asking for plexi a closure for the nursing station because now we have forensic patient, and the temperature is extreme also, and also wheelchair on the unit. We've had to use, we cross using wheelchair for each patient, and this leads to cross contamination. We also don't have hot water to wash our hand. We were told to run hot water for like 5 to 10 minutes before the hot water comes on. We don't have the time as nurses to do that. Thank you very much.
Thank you. Mr. Leonard.
Good morning. Hello, committee. Committee on Health. My name is Leonard. I've been a longtime DC resident and DC government employee for over 15 years. I'm here today with my testimony seeking change for the operations at the hospital. The key concern regarding the operations related to the availability of supplies, staff, and our patients' individual and care. I work as a material handler and therefore responsible for providing supplies and throughout the hospital, clinical staff, patients, and administrative areas. I have 3 key points. Number 1, there's a need for honest discussion on availability of supplies, technology funding for the current reoccurring ordering. We can no longer sit back and allow another day to go by without making essential medical and PPE supplies available for staff and patients. The IICs of the hospital, the safety of workers, patient care is of great importance, and it is concerning that there has been a consistent downward shift in how supplies are funded and ordered and stocked. Number 2 is a lack of accountability in staff repeatedly notifying management of their concern on this topic. The district can investigate fraud, leave abuse, theft of property, and other matters, yet we have not addressed the reoccurring shortage on supplies. The hospital has failed to ensure the safety of operations program directly connected with the patients and individuals in care. Example, failures include consistent failing to provide treatment and medical supplies. The supplies are being ordered and received in delayed manner regularly. Number 3, I come before you to share publicly how concerned I am working in these conditions. My work duties place me in this position where I am viewing empty shelves routinely. Clinical units must go to their adjacent unit workplace to obtain supplies when is completed depletion of need of items on our stock. The job I show up for literally is falling apart before me. I leave you with this final thought. It is 2026, and the hospital operation is manual counting system for tracking supplies level. We do not have a modern technology or standard operating system to supply management. We need help asking A hard question. Demand answers. Staff and records can confirm my statements. It is important that as I'm here today, and public publicity affirming the commitment to my coworkers and patients of the hospital, simply urging the change under realistic procedures with the goal of addressing the vigorous operation and challenges. Thank you.
Thank you. Mr. Thomas, before you start, for those of you who are standing, you are making security incredibly nervous. So you guys can take your seat. I've noted it. You're making them nervous. So if y'all could just take a seat, the solidarity is noted, but we need you to take a seat. Okay. All right, Mr. Thomas.
Good morning, Councilmember Henderson, Councilmember Crawford. Thank you for hosting this roundtable. My name is Hans Thomas, and I've been a BHT at St. Elizabeth's Hospital for over 10 years. Currently, I work the evening shift on Unit 1F, where we house up to 26 patients. Like many of my colleagues, I could list in great detail maintenance, engineering, and staffing issues that continue to go unresolved. However, there's a more important issue that I wish to spend my time speaking about today. Unit 1F is one of St. Elizabeth's 2 all-male pretrial admission units. As such, our acuity is notoriously high, and Code 13s are all too common. Hospital-wide, in fiscal year 2023, there were 386 physical assaults. In fiscal year 2024, there were 471, and in fiscal year 2025, the number had risen to 600. To date, for this fiscal year, we have already had 189. In the past 10 days, on my unit alone, we have had 6. DBH has stated that there have been, and I quote, major initiatives that hospital leadership has initiated to improve overall safety and reduce workplace violence. But the trend that we see is clear. Physical violence at St. Elizabeth's Hospital is increasing year over year at an alarming rate. Whatever initiatives have been implemented, the 55% increase in physical assaults over a 2-year period proves them to be laughably ineffective. The fact is that all of the problems that the hospital faces are intertwined. Lack of basic hygiene supplies like soap and toothpaste, because our orders don't get filled, increases patient stress, which leads to more instances of physical violence. Patients being uncertain that their needs will be met because the unit water fountain is broken or only one washing machine works, increases patient stress and leads to more instances of physical violence. Being unable to control the temperature on the unit because one of the primary HVAC systems broke down months prior, increases patient stress and leads to more instances of physical violence. Being chronically understaffed to the point that we can't spare the manpower to take patients to the gym, sometimes for weeks on end, increases patient stress and leads to more instances of physical violence. Unless and until these fundamental services can be provided reliably, we will never see a decrease in violence. It doesn't matter what initiatives are implemented, how much trauma-informed care we have, how many security officers can respond to codes, or how often we go through safety care training. Our mandate is to provide for the care and well-being of our patients. Meeting their most basic needs is critical to that end, and we are failing. Thank you for your time.
Thank you. Thank you to group of witnesses for your testimony. Mr. Leonard, I wanted to follow up with you. So I think we've been having this sort of ongoing conversation about what the inventory management system looks like for the hospital. I've gathered that. When I met with Mr. Chastain in December, I asked this question, I feel like 6 different ways. And he explained that there are individuals who, they go to the supply closets. They're the ones who deliver things to the particular unit. And I believe that you are one of the individuals that he was talking about. If you turn your mic on so that the folks can hear us online. But my question was, is there an online system such that, if you're low on toilet paper, somebody knows either in the procurement, it's time to submit a new request, those types of things. What does the online system look like?
It's an email thread that the whole hospital gets. I heard the last meeting that y'all was at and him saying that we had a system. With the system that he's saying that we have, It's an email thread that the librarian made up for the whole hospital to see where all the facility people to see the emails that come out.
Yeah.
So I'm a material person. I deliver the supplies, but I get emails for broken toilets, the ceiling damage, lights are out, overcrowd my email bag, so I can't really focus on my part, my task.
So the email with regard to supplies is the same email with regard to work orders?
Yes, ma'am.
Okay. So how, there's so many questions. Who is responsible for tracking? Or rather sort of aggregating, right? Like, is there somebody moving this to an Excel document or?
So I'm the supply person. I deliver directly to the units. The person that actually does the ordering is James Jones. His supervisor is James Dover. So James Jones is the one that's putting everything on the spreadsheet to my thoughts. I'm not sure. I don't see none of that. We don't have a system. I get an email from 1A. They say they need toilet paper, body wash. If it's on the shelf, I deliver it. If it's not, I take a picture and say it's not there. So all my emails, I respond with photos back to the emails.
Okay, so if the supply is not there,
Then it's not in stock to me because it's not on the shelf.
correct. But what you're saying is you take a photo and you send the email back to whom?
So the email thread, let's say it comes from her.
Okay,
It'll come to the TMS website. So it's four of us in our department.
okay,
All of us get the email, plus the maintenance, plus the administrative staff.
okay.
I see my own stuff, so I pulls mine from my phone and I do everything from my phone so I can snapshot it. So when you send me an email, I can send it back and let you know the item that I got. I take a picture of the item that I put in your box. And if it's something that's not on the shelf, I state that it's not in stock, contact management for further instructions.
So she would get an email back that says contact management because it's not there?
Yes, ma'am. Because I can't provide and tell you when it's coming or where it is. If it's not in the stock room, it's not in stock. Because the shelves should be full with the things that we're supplying for the units.
Sure, but if she's a nurse.
No, I'm just.
No. We're doing a
Oh,
hypothetical.
no. Okay, I get you.
If she's a nurse on a unit doing patient care, but now she has to contact management about no shower
So
gel?
the purpose of that is to protect myself
Okay.
and for her to know that it's not in stock. But since somebody is supposedly monitoring the system,
Oh,
they'll see it.
because you replied back to the whole
Yes, ma'am.
email thread.
Yes.
I see.
Mm.
Also, this is giving very 1992.
Right.
Okay. Mr. Thomas, let's talk about assault. So we sent the pre-hearing questions. We asked about the number of assaults because this is something that you all have been talking about for a long time.
Yes, ma'am.
And I remember distinctly somebody saying, well, this is what you signed up for, or a quip. That was sort of the response, which I don't believe that anybody signs up to come to work to be assaulted. And the number of assaults are increasing in a way. I mean, even in terms of so far this year, 189.
As of the time that this was submitted. So I
Right.
don't know exactly when that was.
So that means that this is most certainly on track to be much higher
Than the 600 we saw last year.
than the 600 last year. What was interesting to me is that in the response that we received from DBH, they said they do not track assaults disaggregated.
Mhm.
So I can't say how much of that is patient on patient versus patient and a staff or anything
Correct.
to that regard. I think that's concerning because when you don't disaggregate the data, it kind of masks in a way, right? If it's 600 assaults is a lot for anybody. But if 90% of them are directed towards staff, we got a problem.
What I often see on the unit, well, what often happens is if there's a physical event between patients, it's on staff to break it up. So these become multiple instances against both patients on patients and patients on staff.
Okay.
Staff is, of course, sometimes targeted directly by patients, certainly. But the numbers, I think, increase by the nature of how many people end up getting involved to break up fights.
I see. I also would say that I think perhaps some of this is a function of how the population at St. Elizabeth's has changed, where there's
Sure.
now such a large forensic population.
Large forensic population, younger, and we're fuller, right? Like, so we're at capacity now. So every time we get a discharge, we get a new admission that day from the jail. And this systemically increases our acuity because there's no time for it to come down, right? When we have like a few empty beds on our unit, for example, we get a new person, they have some time to acclimate before we get more new people, right? So they get adjusted, medication starts maybe, blah, blah, blah. The acuity comes down. But when we're filling every bed as soon as it opens, that just ratchets up without any time to stabilize. Because our lowest acuity patients are the ones that are moving on, back to jail, back to other units,
Yeah.
et cetera, et cetera.
Okay, I'm over my time. Councilmember Crawford, you have any questions for this panel?
Thank you, I do. I want to circle back to the issue of overtime and scheduling. So Ms. Kadahar and Ms. Olugbemi, I believe you both mentioned scheduling challenges and how that connects to issues with overtime. Can you elaborate on those scheduling challenges? For example, when are escort schedules supposed to be released?
Gotta use your mic.
For 1A, for example, on day shift,
Mm-hmm.
when they send in the staff list, that's where the escort names are mentioned. And there are times that it's the unit staff that we go with the patient to maybe dialysis or outside clinic.
But when do you receive that?
In the morning, like sometimes, because I work night shift. So it's supposed to come in like before 7. Sometimes we don't get it until like 7:11 a.m. in the morning. And it's supposed to come in before 7.
Okay.
So,
This is currently the standard practice when you
yes.
receive your schedule. Okay.
Yes.
And who do you receive your scheduling from?
Okay,
Yes.
we have people in the nursing office there, also registered nurses called nursing supervisor.
Mhm.
And they tend to just man one shift or maybe extend to other shift, but they are the one that do the staffing list and then send it to us.
And I'm asking because a witness who's going to testify later said that now scheduling is coming from nursing supervisors and not the supervisors themselves.
Yeah, it's
So,
the nursing
is that
supervisor
typical?
in the nursing office.
Okay.
Yes.
Okay. So I just want to make sure I understood that. And then let me just see here. So when staff escort patients to those outside appointments, this is directly impacting for the staff that is still at the hospital overtime, right? So then on the prior panel, someone said we can't leave. And I was trying to understand what that means because we can't leave. I want to know what that means. So can you connect the scheduling issue to overtime, if there is a connection?
Well, for example, on the day shift, as I'm leaving, there's always a struggle between, okay, who is supposed to be on the unit and who is going out with the patient. And so at the end of the day, when a staff is assigned to clinic outside, it diminishes who is supposed to be working on the unit. And then nursing office might be scrambling to look for somebody to stay or to come over as overtime or whatever it is for them to cover the unit staffing.
Okay, thank you.
Mhm.
Yes. My team and I also want to ask about what kind of support is offered to staff following the violent incidents at the hospital? And I'll ask, that sounds like none, okay? You can say that on the record.
Purportedly, there is an employee assistance program that's supposed to provide emotional support for staff after an event happens. As someone who has been injured, the process for me looked like this. First, I go to the medical office to get examined, and then I go to the hospital for imaging when I injured my knee. If it's a serious injury, which it wasn't in my case at the time, Another staff member is supposed to go with the injured staff who will wait with them at the hospital until a family member arrives. That has happened when staff has had heart attacks, for example. I know that has happened. But there is no follow-up for like well-being, wellness checks, unless you end up as a workers' comp case, getting compensation in that way.
Thank you. I'm sorry to hear that, and we'll definitely follow up on that with the government witnesses. Thank you.
Thank you to this panel. Mr. Thomas, just a clarifying question on that. Is there an investigation that takes place?
Yes. There is, I'm forgetting what it's called specifically, but yes, there is an investigation team that looks at instances primarily involving patient injuries rather than staff injuries, risk management, and they will do investigations. Most often our involvement with them is when they're investigating allegations against staff for patients that have been injured, rather than.
I'm sorry, allegations against staff. So you all were, or staff was the aggressor towards a patient?
Allegedly, correct.
Allegedly.
Yeah.
Okay.
Primarily, that's when I see them get involved, rather than the reverse, where staff has been injured by a patient.
I would think from a risk management perspective, there would be an investigation on any incident that occurred.
I'm not a risk management person.
Yeah, okay. All right. All right. Thank you, Mr. Thomas. Thank you to this panel of witnesses. Thank you so much. Okay, we're gonna go to the next panel. Raymond Akin Lasutu. Oh, okay. Beverly Mcny. Is it Magdalene is not here? Oh. No. Are you Beverly? Okay, yes, you're fine. No, Magdalene Albagay? Not here. Okay. Ngozi? Nimbunzu? Apologies for. All right. Katarina Samanova? Okay. +1 to answer questions. I don't see Mr. Branham. Unless I missed Tamara Butler. Okay. All right. Ms. Samanova, if it's okay with you, we're gonna ask for Miss Beverly and Miss Tamara to go first, and then you'll go from there. All right.
Good morning. My name is Beverly McElhaney. I am a behavior health technician assigned to the admission department as escort services at the Department of Behavior Health. I am here today to discuss critical patient care, safety concerns resulting into ongoing failure in scheduling, supervision, and staff with our department. My direct supervisor is responsible for coordinating and covering critical medical appointments. Since COVID, we have not had a supervisor consistently present at work, and this has affected daily operation. As a result, escort scheduling is often created by the nursing supervisor rather than the supervisor that's assigned to the missions. These schedules are frequently not provided before the shift began and changes after the shift already started, leading to confusion and inefficiencies. Department policy requires that escort schedules be prepared in advance and accessible to staff to ensure safety and coordinated patient care. These policies are not consistently followed. On several occasions, I began my shift at 7 a.m. and the escort schedules was not available for 1 hour later. I have received information that was from I have received information that's different from my colleagues, causing significant confusions and operational breakdowns. These failures have had serious consequences on the individual in care. Patient has missed vital medical appointments, including dental, physical therapy, and podiatry. Missed follow-up appointments increase risk of delayed diagnosis and treatment, placing patients in unnecessary risk. I have observed ongoing breakdowns in the tracking, clinical appointments, and discharge statuses. Department policy requires that a discharged individual be removed from the active schedule, yet this safeguard is routinely ignored. I've documented an incident where overtime staff was hired to escort a patient that had been discharged for over 30 days. As a result, active patients were left without necessary escort coverage. Despite submitting written concerns, no corrective action has been taken. After raising these concerns, I experienced retaliation, including being restricted from my area where I am assigned to pick up a schedule where it's posted. I was excluded from receiving the information that can help me perform my duties. These actions interfere with my ability to advocate for patient safety. My goal is to ensure that every individual in care receive timely and appropriate medical treatment. When operational concerns are ignored, patient care is further jeopardized. Thank you for your attention on this matter.
Thank you. Ms. Butler. Nope, you don't have your mic on. There you go.
Can you hear me now?
Yes.
Okay, my name is Tamara Butler, and I'm the pharmacy technician data for 35K DBH agency, and I'm also the executive secretary treasurer for 2095 local union. My position is the pharmacy data tech, and I'm currently the only person in this role for the agency, and I have been the only person in the role for in this agency since 2013. I work directly with pharmacy systems, data, and workflows that impact medication use and patient safety. IT's role is to support pharmacy by ensuring systems function technically. IT staff are not pharmacists and cannot make changes to formularies or medication bill. The clinical responsibility belongs to the pharmacy, to which I belong. When these roles are blurred and when pharmacy staff are not properly trained on the systems they use, patient safety is put at risk. This has led to medication errors, overdoses, system failures, repeated patches, and overhauls across 35K Street Pharmacy, CPEP, and St. Elizabeth's Pharmacy, St. Elizabeth's Hospital Pharmacy. I began working in 2013 where I was hired as an expert to implement the Pyxis system because we were still working on antiquated systems then, as well as the pharmacy host systems. After a later system update with limited testing, investigations revealed that multiple patients were being overdosed by the dozens due to system-related failures. I reported this to my pharmacy supervisor, IT, nursing leadership, and the hospital CEO. I was asked why we couldn't all get along. I was told that we should be friends. Instead of these being addressed as patient safety concerns, my communications were later reframed as a personal dispute with my supervisor, which shifted the focus away from system failures and medication risks. I was moved to another facility, C35K, in 2019 to assist with the implementation and management there, where the same problems continue. Systems do not communicate. They are antiquated. Doctors are asked to put their their orders in multiple systems, which is ineffective. Lack of training and medication safety concerns with poor incident reporting and internal handling continues, which minimizes escalated serious issues at all locations. From a system management standpoint, updates alone are not enough. There remains a critical need for structured governance, formal change management, and standardized testing before go live. Clear documentation and ongoing training with independent review of related incidents. We cannot depend on the department that does clinical reviews to also manage the system. It is ineffective, and there is a lot of lying. When technical oversight sits under the same department responsible for clinical outcomes, system failures and safety risks can be filtered or minimized instead of escalated transparently. Housing this role under IT and all pharmacy independent roles under IT provides independence and auditability and objective review. Now, with the recent notification of relocation of 35K Street and CPEP to St. Elizabeth's, I'm not sure where CPEP is going, I, as the data technician, am being asked to move back under St. Elizabeth. Under a hospital environment where leadership has not demonstrated an understanding of pharmacy as informatics, system governance, or transparency in patient care. My purpose is not to assign blame. It is clearly to state that without proper role placement, this does not work. We will continue to repeat the same failures at all 3 locations. Patient safety, medication accuracy, and transparency is non-negotiable, no matter who is in charge. And finally, as a mental health agency, we must also ask what safeguards are put in place to protect the well-being of the employees. Too many times in my department alone, my staff has left, licenses are being applied by other staff persons where these persons no longer work, and there are things that are happening that should not be happening. There is no integrity or safety of employees' licenses or the staff. We are being bullied and we are being told not to ask questions because management do not have the answers. Thank you for listening to my testimony. I
Thank-
appreciate it.
Thank you. Ms. Butler, you're sitting next to 2 lawyers who were writing notes. Ms. Samanova, when you're ready. Yep.
Thank you for the invitation to participate in this roundtable regarding St. Elizabeth's Hospital. I am Katarina Samanova, Special Counsel to the Director on Policy and Legislation at the Public Defender Service. Layla Thamer, longtime attorney in the Mental Health Division at PDS, joins me today to answer questions. By way of background, at any given time, PDS represents more than 40 people who are housed at St. Elizabeth's. The vast majority of PDS clients at St. Elizabeth's have daily struggles with medical and psychiatric care. Many clients are elderly, and while they were initially placed at St. Elizabeth's as a result of a psychiatric diagnosis, they now primarily struggle with age-related dementia and other conditions related to aging. St. Elizabeth's does not have appropriate services for these clients. These elderly clients have suffered from bed sores, persistent infections, and have had their medical needs ignored. Placement in a psychiatric rather than a memory care setting has also exacerbated cognitive decline. Lawyers have also noted the inadequate management of psychiatric illness at St. Elizabeth's. For example, clients have had dangerously high levels of lithium, seemingly because St. Elizabeth's was failing to monitor levels. Other clients have experienced abrupt discontinuation of psychiatric medications. On numerous occasions, the Commission on Mental Health has had to order a medication review based on the Commission's concerns about over-medication or inappropriately prescribed medication. St. Elizabeth's also routinely fails to meet client basic needs. There have been delays, seemingly caused by staff shortages, in getting clients eyeglasses, dental care, x-rays, MRIs, and the medical exams that they need in order to proceed with necessary psychiatric treatment. St. Elizabeth's has also failed clients when the hospital has ample notice of the client's need for care. For example, one client entered St. Elizabeth's while pregnant, and hospital staff had sufficient time to plan for postpartum care. The client delivered her baby at an area hospital and made it clear that she intended to breastfeed. Upon her return, she was repeatedly denied a hospital-grade or even electric breast pump and was told to express milk with a manual pump and that she could only do so once a day despite engorgement and severe pain. It took days for St. Elizabeth's to authorize the receipt of an electric pump. St. Elizabeth did not honor or recognize the standards and the law that the Department of Corrections must adhere to after delivery and during breastfeeding. Clients report terrible and unhealthy food at St. Elizabeth's, mostly consisting of white bread and pasta. Clients report a near total lack of fresh fruits and vegetables. As a result of the diet at St. Elizabeth's, clients have had significant weight gain and have developed diabetes, hypertension, and sleep apnea. Many clients at St. Elizabeth's also have no access to fresh air and have not been outside for months. Further, St. Elizabeth's was built to provide 2 treatment malls. The treatment mall is where patients receive services and therapy, including the primary interventions such as music and art therapy, and where they learn social skills that are intended to help them recover and be able to leave the hospital. During the pandemic, St. Elizabeth's decided to close one treatment mall and use it as a quarantine space. In the years since that decision, St. Elizabeth's has never reopened the second treatment mall, and now everyone has less time at the treatment mall. This decision stalls recovery and prolongs hospitalization. We also want to again raise systemic issues at DBH that negatively impact patient care at St. Elizabeth's. Many individuals remain hospitalized beyond when they are medically ready for discharge because they lack necessary housing. The problem stems from inadequate case management and DBH's failure to dedicate resources to alternative forms of housing, which is readily apparent in the 20% reduction in the capacity of DBH's supportive housing residence program from 2022 to 2025. There are also a significant number of patients at St. Elizabeth's who are waiting for nursing home placements that will never materialize. This is a foreseeable consequence of the district closing the 120-bed public nursing facility at United Medical Center. Since the 2023 closure, the district has not built or even contemplated building a new facility that would address the needs of this population. The failure to move clients to nursing homes and the failure to maintain other forms of housing tie up critical bed space at St. Elizabeth's. Individuals waiting for bed space are forced into dangerous and untherapeutic settings such as PIW. Further, DBH cannot meet the mandate of the Irvin Act, which provides that the district's public hospital shall admit an individual for voluntary treatment if an examination reveals the need for hospitalization. Because St. Elizabeth's refuses to admit voluntary patients, those patients instead have to go to CPEP for assessment and then to local hospitals where they can only receive short-term voluntary treatment. More capacity created by moving people from the hospital to appropriate placements is necessary for St. Elizabeth's to truly serve the community. Thank you for having this vital conversation. PDS remains available to the committee for further discussions and welcomes the committee's work in this area.
Thank you. That was a lot. I'm going to go over 6 minutes. To everyone, if you have not, this is for everyone, if you have not submitted your written testimony for the record, if you can go to the website and do so, that helps us in terms of referring back later. Ms. Butler, though, before you leave, if I can have your testimony, that would be great. I want to ask some follow-up questions. Okay, so Ms. McElhaney, escort services is supposed to be able, and I'm saying this out loud just to sort of paint the picture for people. So your role is you are moving someone, say, from their unit to a treatment appointment that they might have? Okay, turn your mic on.
Yes, that would consist of whether it would be an in-house medical appointment, which would be anywhere from physical therapy, diabetes, dental, and podiatry, and also outside medical appointments as well.
Okay, so you guys would be the ones who do the transport.
Yes.
Okay. Now, Ms. Samanova said in her testimony that there used to be 2 treatment halls, but now there's only 1. Is that?
That is accurate.
That is accurate. Okay. Have you all inquired as to why the reduction of services were made available, even though the population of patients in need of services has increased? Oh, sorry. Okay, hold on. Are you saying you wouldn't know?
Yes.
Okay, Ms. Samanova, have you guys inquired on behalf of your clients as to why?
Our understanding, what we've been told, is that it had closed originally because of COVID, but we have not received any additional information as to why it hasn't reopened or why other alternatives haven't been offered to our clients who, the treatment module is so important to St. Elizabeth's purported care for clients. And we have not really received adequate information as to why they haven't resumed the level of therapeutic classes and activities they offered pre-COVID.
Do you have clients for whom could use those treatments but have not been able to be scheduled because they're of availability?
We have just observed that the number of classes and the hours of therapeutic interventions is far less than what it had been before. So that's our concern. And we have so many clients who are at baseline and who are discharge eligible and who are basically being warehoused at the facility because of this lack of housing issue. And so these are clients who could really benefit from being involved in discharge planning courses and social skills and coping activities so that they can successfully transition to the community, but they're not being able to access those kinds of care.
The availability of step down housing options is a challenge, not just for us, but also for the region, but even more so is if I'm thinking about other conversations that are separate from St. Elizabeth's in terms of what the Department of Behavioral Health has available to them. The only thing I think they have are vouchers available, but for some of your, some of the patients that we're talking about, independent living is perhaps not the best thing for them. But I think even Ms. Samanova, you're talking about they might need to be in a memory care setting, as opposed to we just put you in an apartment on Wisconsin Avenue and hope for the best.
And Your Honor, or Councilwoman Henderson, the problem with our geriatric clients who, again, are at baseline, who are facing issues that are primarily related to their age in terms of dementia or physical deterioration, they really shouldn't be at a psychiatric hospital. And so it's just not the appropriate setting for them. And a lot of the private nursing homes will not really adequately consider psychiatric patients for admission. And there's no public nursing home for our clients to transition to. And so it's really, they're not really being afforded the least restrictive setting, which they're entitled to under the Constitution and the Irvin Act. There haven't been alternatives, for instance, considering a home health aide or considering other housing options. So for this category of patients, they're really just being kind of warehoused at a facility that doesn't have care that's tailored toward their needs.
Yeah.
And in fact, they're on acute wards. They're not really in the environment that's going to optimize their well-being.
Yeah, I mean, I'm sure if I talked to Miss Olugbemi from earlier, she was a nurse on Unit 1A. She says, I guess that's a geriatric unit. She probably would sort of corroborate that there's some individuals on her unit who need a different setting.
Correct.
As opposed to a psychiatric facility, because it may not be that acute level, but there's something else going on. And St. E's is like the default.
Correct.
Okay. Oh, go ahead. Yes, ma'am.
Yeah, because right now what Department of Behavioral Health.
You just got to lean into your mic.
Right now, what the Department of Behavioral Health is doing, they're mixing forensic patient with civil patients all over the hospital, which is unsafe.
Yeah. Well, and I think even to what Ms. Samanova was saying, and we've heard this, right? If a patient from the community who is not forensic was seeking care, there actually isn't really a bed available for them at St. Elizabeth's at this time, given the number of forensic cases that are currently there. I want to ask Ms. Butler, again, you covered a lot in your testimony. But can you say more about the systems being antiquated? So I keep hearing, oh, we're updating, but perhaps we're not updating to current, but we're updating to something that was like from 10 years ago.
So I'm actually not a part of those conversations, even being the pharmacy data technician. I'm left completely out of those because I'm a person who reports usually on the issues.
Okay.
When we started, they didn't have any PICSA systems. They were still using a manual cart system for medication. So that's why I was brought in 2013. And when I moved over to CPEP in 2019, well, 35K in 2019, CPEP was being moved over from their bag system. They just had a room with medications all over the room and no real system. So we actually transitioned them. And we use the pharmacy system Ascend, which we use across all 3 locations. And the pharmacy host system, well, the pharmacy information system we use is Credible because that's used in the community. But Credible doesn't communicate with Ascend. So what we have our doctors do at CPEP is the doctors put the orders in Credible. Then the doctors go into the pharmacy system, which they shouldn't have access to, and they put the orders in there. And then the pharmacist at 35K verifies the orders. So we have the doctors actually working in two systems, which has caused a lot of confusion because sometimes the doctors just don't want to do it, or they feel as though the system is so antiquated, they will miss a step. So for the last 6 years, we've been constantly going back and forth about the systems not talking. Typically, what you'll see in a hospital or a system environment is that the order is put in the hospital information system.
Mhm.
It goes across to the pharmacy host system.
Yep.
It goes to the ADM. That doesn't happen with us. That just isn't something that we do. So we've adapted to these workarounds. And now with the relocation of CPAP, which I'm hurrying through third parties because I still haven't been communicated to that.
This was news to me.
Oh, okay.
And I chair the committee. I
It's-
was like, oh, CPAP is moving.
Yeah,
Interesting.
CPAP is moving and 35K is closing to go to St. Elizabeth's. So my topic here is what am I going to be doing in the grand scheme as the pharmacy informatics person, because my supervisor, Dr. Jonathan Shepard, who housed 35K, he hasn't said a word to me about it. I've just been informed through the union. So I have no idea how the operational standpoint is supposed to work because I have no idea what I'm supposed to do. And when this was under St. Elizabeth's before their wonderful upgrade with ES, they didn't know what to do either.
So I'm honing in on this because when we talk about pharmacy, there's so many rules for pharmacy, right?
Yeah.
And I know this from our oversight in terms of DC Health. There are federal laws that you have to
Correct.
follow for pharmacy. There are license implications when you get pharmacy incorrect. And so, but also when you're talking about a psychiatric facility where you have a number of individuals who are in different combinations, it's super important that you know who's receiving what, when, how that interacts with something that they might be on or not. We have the same conversation with DYRS in
Yeah.
terms of what's happening with young people who might be receiving psychotropic medications, et cetera. But you said it's not just tech, it's also about structured governance.
It's about structured governance. And I mentioned that because we're under the impression that because pharmacy or the pharmacy tech position is in pharmacy, that pharmacy directs traffic on that. But really it's more of governance, because what we saw a few years back when I had reported it to Martha Pontes and Mr. Chastain and Mr. Singh was that these overdoses were happening and I was being hushed. I was being told not to communicate with IT. I was being told that we were having communication issues internally when that wasn't the case, that I was the system administrator and I was supposed to report and find out what was the issue. So I ended up having the union represent me in most of these meetings with leadership because it was not being advisable or the communication wasn't getting passed. And ultimately I was just rotated out and moved over to 35K where I've been for the last 6 years.
Can I ask the question? You did say that you're the only person in this role since 2013. Is that across all 3 sites?
So I support the hospital if IT has questions. Yes, I am the only person, and I also do frontline at 35K. So I'm the frontline technician because we've lost our staff, and we do deliveries to CPAP. So 35K Pharmacy manages the medication systems for CPAP. CPAP doesn't have their own pharmacy staff. They use us. So right now, I'm the only government employee that works at 35K because everyone else left or retired out. Which also raised questions because I had staff over at CPAP applying for their licenses under my employees that had retired. So I've been working under people licenses that were no longer employed with the district, that were no longer functioning, which I've reported. So the conversation is so big because when you're in a position and you're the only one, what happens is that you're stifled down and told, we don't want her in the room. We don't need her communication. We're going to do this with this position. And she'll just have to go back and forth between wherever she's going to end up. But the bigger conversation is governance because we do not have people who understand how systems function. They have no idea. They've never worked with systems. They're being taught in real time. And what happens is we have a lack in patient care and continuity of care on the consumer's end. So when we tell our nurses, hey, you made a mistake, you gave a patient 5 doses of Depakote. Well, that's what the system told me to do. And then I go in and I do my reporting. Oh, we didn't set up the frequency, so it's wrong for every dose. None of the frequencies are right. So all the patients, you're getting this once a day. You were supposed to get it once every 7 days.
Do you log when mistakes are made?
So typically when I was under St. Elizabeth's, I was documenting it and I was per my supervisor, Dr. Hyon Lee, I would tell her. She asked me verbally and in meetings to stop communicating with IT, that she prefers to be the only person that communicates issues. So we would start having conversations internally, and those were not to leave the pharmacy. She would handle those outside. As with Dr. Shepard, when my nurse at CPEP applied for my pharmacist license because she said she's done it before, we were told that he would handle it. And our question was, should we still be operating under a person's license that no longer work? We were told that conversation wasn't for us. We still come to work every day.
I'm going to guess that answer is no. A strong no. And okay, I think that's as far as we can get on today.
Yep.
On that question, but I would like your testimony if possible. Okay. Ms. Samanova, we might have some follow-up questions for both of you as we go forward here to try to figure out what are the next steps. But thank you. Thank you all for being here. Okay, we have our final three in-person public witnesses, and then we have 4 individuals who signed up to testify virtually. So if you're virtual and you're listening, we're about to come to you, so don't step away. Mary Musa, if I'm saying that right, okay, thank you. Antionette Clemens, and Sarah Boyd. Oh, okay, Ms. Thomas, sorry, yes. All right, Ms. Musa, when you're ready.
Good morning, my name is Mary Musa. I'm a registered nurse at St. Elizabeth Hospital. I would like to address several pressing concerns regarding hospital operation, staff treatments, and patient practices that I have observed during my time at St. Elizabeth. Firstly, I want to highlight the misappropriation of resources that management have committed. I have seen skilled registered nurse being assigned to a modified role that is not, that do not align with her professional expertise or training. This misallocation of human resources not only affect the staff morale, but also lead to inefficient use of hospital resources. Staffing shortages in critical areas such as escorts, utilization, medical records, chart editing, all those areas and ignore. So this destruction in delivery of patient care and management of resources. Secondly, I must emphasize the issue of unprofessional conduct and poor communication. I have repeatedly observed and experienced the respectful behavior among staff and management communication has often been unclear or dismissive or totally ignored, no reply. The lack of effective communication negatively impacts not only by the staff morale, also create a hostile working environment and ultimately destroy the coordination necessary for optimal patient care. Another significant concern is the unfair treatment of employees. I have witnessed inequitable treatment that appear to stem from favoritism. For instance, an employee requests reasonable accommodations under similar circumstances have been treated differently. In one case, an employee was denied necessary accommodation, while another one received multiple positions. Such irregularity raised serious questions about fairness, transparency, and compliance with workplace standards. Moving on to our clinical system, as they have said, our system is fragmented. Nurses use multiple systems to do their work. and none of them integration. Yeah, I want to point out that they lack integration. Nursing staff are required to use multiple systems for patient care, but the system do not interface with another. This disjointed approach increase risk of documentation gap, treatment delay, and error in patient care, jeopardizing patient safety. Lastly, the lack of irregularity across units. Each hospital units operate differently, different standards and procedure, creating confusion and inefficiency and ultimately affect patient care outcome. In conclusion, I submit this testimony to underscore the urgent need for improved operational oversight, equitable treatment of staff, and stronger safeguard to ensure patient safety and quality of care at St. Elizabeth.
Thank you.
I thank you for providing me with the opportunity to testify here today.
Thank you so much. Ms. Clemens.
Good morning, Chairperson and members of the committee. My name is Antionette Clemens, and I'm the program specialist / medical clinic coordinator at St. Elizabeth Hospital. I have been serving in the government for 47 years, including decades at St. Elizabeth Hospital. I am here today because the conditions in the medical clinic represent systemic operational failures that place patients' care at risk. For years, the medical clinic operated with one staff member, that would be me, and coordinating the care for 270 and supporting 12 physicians. Only recently was a second staff member added. While helpful, this still equate based on patients' volume and workload. The clinic requires at least 3 permanent staff to safely manage and scheduling, coordination, and follow-ups, because I have other duties other than scheduling. The chronic understaffing has resulted in missed appointments, delayed specialty care, and growing backlogs. Currently, we still have approximately 20 outside consultations still pending, including essential services such as ophthalmology. These delays directly affect patients' health and continuity of care. The situation worsens when the escort and the driver positions were eliminated. Patients routinely miss appointments because there is no escort or transportation support. As a result, appointments are wasted, public resources are misused, and patients wait longer for care they're urgently needed. Despite repeated and documented requests for help, management continues to assign all operational responsibility to one individual without backup, without proper classification, and without appropriate compensation. When that individual was unavailable, when the individual is not available, when I'm not available, the coverage was not provided. Appointments accumulated, backlogs grew, clinic operations stalled. This was predictable and preventable. Temporary staffing solutions was given to me to help while presenting the failure because they did not address the root problem. When consistent staffing was finally provided, clinic performance improved immediately. Providing this crisis instruction, not a failure of an employee's effort. There are also combination failures, particularly involving patients from the Department of Corrections, that lead to unnecessary appointments and waste of resources, further straining the clinic. Most concerning, when staff raised these issues professionally and in good faith, they were cut off in a meeting, excluded from the discussion, told that someone would contact me to talk to me. No one ever did, then later criticized in the evaluation. These creates a chilling effect and discourage employees from advocating for patient safety. Let me be clear. The medical clinic continues to rely on persons as its operational backbone. Without safeguard or accountability, that is not safe, sustainable, or acceptable in the district hospital. There are systemic failures, not minor inconvenience. They threaten patients' care, staff well-being, and public trust. I urge that this committee to require adequate permanent staffing and restoration of transportation and escort support, clear accountability and protection for staff who speak up for patients' care. The medical clinic at St. Elizabeth Hospital cannot safely continue urgent care conditions. Thank you for allowing me to and commit to the health of the district.
Thank you. Sarah.
Hi, I'm Sarah Boyd. I'm a
It's on.
Okay. I'm a licensed clinical psychologist. I live in Virginia, but I have been practicing in DC since about 2012. I've testified in federal court, superior court, special education due process hearings, a variety of settings in DC. I submitted written testimony so that you all would have the opportunity to read some additional background that's a little bit more academic, I guess is one way of putting it. And my focus has primarily been on seclusion and restraint specifically. One of the things that I don't often tell people about my work, but is true, is that I was a direct service provider for about 10 years. Actually longer than that, from the time I was about 17 until my late 20s, all through grad school. I was basically a caregiver for individuals with developmental disabilities who had serious support needs. I worked in institutional settings that were like nursing homes and hospitals. I took care of people who were in their homes. I took care of people in group homes. I did respite. It was really the full gamut. The first time I was ever punched in the face at my job, I was 17 years old. I've experienced a number of different kinds of assault in that capacity. Never once have I ever thought of it as the fault of the person whose body made contact with my body. Every single one of those experiences typically could be traced to a failure of some kind. Sometimes it was a mistake that I made. Sometimes it was a mistake that my employers made, but there was always a reason that these things happen, and they were nearly always preventable. I remember at the time when I was a direct support provider making $9 an hour and feeling lucky, working into these conditions, trying to report the things that I was seeing or mistreatment of the people I was taking care of, and the understaffing. And I remember thinking to myself, someday I'm going to go to graduate school. Someday I'm going to have letters after my name, and someday I'm going to be able to tell people about this problem. Remarkably, I have actually followed through on that. And I specialize now in developmental disabilities, in psychological trauma, and also in sexual and gender minority individuals. In 20 years ago, the DOJ wrote a report about the conditions in St. Elizabeth's, and if you reread that report, it's eerie. It is exactly the same problems that I've heard the folks from the union discuss today. They're very similar problems to what I saw. In that report, they also acknowledged that they knew then, 20 years ago, that repeated use of restraint and seclusion and what people refer to as PRN meds, but which are in fact chemical restraints, are unacceptable treatment failures and indicative of a strategy that is not working. Sometimes it's because of understaffing. There's a variety of reasons why this can happen. And there are lots of people who can explain to you why that's a problem. What I want to talk to you about today in the time that I have is what the solution is. I actually have a handout. I'm not sure if I'm allowed to give it to you, but I do have a little handout, and it's a table. The table is an illustration of what's called a functional behavior assessment. This is my recommendation for what I believe that St. Elizabeth's can do to reduce the use of seclusion and restraint effectively while promoting patient and staff safety, as well as recovery for the individuals in care. The handout that I've provided has a table in it that shows the kind of data collection that we would typically do. Interestingly, given some of the conversations today, the example that I chose was an individual who keeps pinching people, which sounds mild, but sometimes that can actually be really horrible to be pinched. And it can draw blood even and cause bruising. In this particular example, I have a number of columns for a hypothetical individual named Milton who keeps pinching people. Every time Milton pinches people, the staff come in and they talk to him, and then eventually they take Milton outside for a walk. The staff at times physically restrain Milton. They try to give him PRN medication. They're wondering why it is that he won't stop doing this, and he's doing it sometimes 40 to 50 times a day. In the example that I'm using here, when we look at the actual data collection for Milton's behavior, when we objectively catalog it at the time it's happening, instead of looking at it in retrospect or guessing,
we can see that what's actually happening is that every time Milton pinches somebody, he gets to go for a walk. He's not thinking to himself, boy, if I pinch somebody, I'll get to go for a walk. But the fact of the matter is that is serving as a reinforcer. And when we reinforce behavior, by definition, it increases. In this example, we implemented a very simple behavior plan for Milton based on that objective data collection. And the plan was basically two things. Take Milton for a walk every day before 10 a.m. for 10 minutes, rotate staff responsibility so it's not the same person doing it every time, and do not utilize walks as a response to pinching. In other words, don't take him out for a walk immediately after he pinches people.
Ms. Boyd, I'm so sorry,
Yeah.
but if you can wrap your about
Yes,
2 minutes
yes,
over. Thank
yes.
you.
The behavior dramatically decreased within 20 days to a baseline of 0 over the course of 3 days. Now you have objective data showing that that plan works. This type of approach could be utilized by hiring experts in board certified behavior analysts who are formally trained individuals who routinely deal with significant aggressive behavior. I believe this is the appropriate alternative in addition to the issues that have been raised by the other individuals who have testified today.
Thank you. Ms. Thomas.
Yes, my name is Deborah Thomas. I am a nurse consultant for the DC Nurses Association. The DC Nurses Association represents registered nurses in the Department of Behavioral Health. And I am here on behalf of these members to discuss how we can assist management in creating a safe environment for nurses to practice. The DC Nurses Association has been working with the administration to secure new avenues of care that provide therapeutic options for improvement. I collect data from a board of nursing approved tool called Assignment Despite Objection. The following criteria are monitored and reported quarterly: nurse to patient ratios, working conditions, patient safety issues, and nurse licensure. These criteria measure factors which contribute to patient safety, delivery of care, nurse licensure, and the ability to meet therapeutic goals. In short, according to this data, nursing needs are not being met. The care environment has diminished in safety for patients and nurses alike. The population is now primarily for forensic, which requires different skill sets. Nothing in the delivery of services has changed to deal with this new reality. Psychiatric nurses are unique and well-trained. For them to do their job, certain factors must always be present. Administrative nurse advocacy is important. We don't have that. Ongoing education and training, safety of the environment to practice, and collaborative medical options. We have very little education and training. We have problems with appropriate orientation. These major factors are not available to support the delivery of safe care. This is not an occasional occurrence, it is everyday occurrence. This means guidelines set by the Department of Health are not being followed. This includes the following from the District of Columbia Municipal Regulations. Each hospital shall provide a nursing staff that is adequate for diagnostic facilities and services and rehabilitation facilities. Safe nurse-to-patient ratios are not being done. Qualified personnel shall be provided in sufficient numbers to provide nursing care, not requiring the services of a licensed nurse, and that's appropriate paraprofessional personnel. The nurse on 1A spoke very eloquently about that patient population. There are no trained nursing assistants to work with that group. That seems like a simple fix. All nursing personnel shall be qualified by education, experience, and demonstrated ability for the position in which they are assigned. That means appropriate orientation, appropriate education staff, and ongoing education and training for the staff. It's very little of that. An environment of care that provides safety and delivery of therapeutic options. Every single day, nurses come to work at St. Elizabeth's. They put their licenses in jeopardy because they don't have the type of support and services they need to do their job. there has truly been very little improvement in any of the variables that we have discussed. The data shows a rapid decline in nurses' ability to practice safely or to keep patients safe. In conclusion, we ask the City Council Committee on Health to do due diligence in helping us create a safe and therapeutic hospital to provide the population in this city decent psychiatric services. These reports are done quarterly. We sit in front of management and speak about these problems. We get nothing in return. At some point in time, I felt I needed to stop going to these meetings because it's just arguing about what nurses are not doing or whatever. I am afraid we're going to wait until something serious happens before some real changes are made. Now, I have also bought a yearly report on St. Elizabeth's with all the data that I have collected for 2025. It is horrific. If you want some experiences in here, I can read them off for you. And I can make sure it is a part of what I'm going to.
Yes, if you can make sure that it's part of the record, or if you want to share it with Ashley and Ms. Boyd, the document that you have, if you can get it to Ashley, she can give it to us as well. Thank you so much to this panel of witnesses. It's a little tough when you're sort of at the end, when you're sort of saying some of the things that have been sort of said from the very beginning. But Ms. Clemens, I do want to ask you some specifics in terms of patients missing appointments due to no escorts and transportation. If someone is to miss an appointment, is that rescheduled, and how, or what is the priority in terms of rescheduling that such that it's not several months later?
Right, well, we have to.
Oh, if you turn your mic on.
Yes, we have to reschedule it. But as I had said before, I was the only one doing this among other duties, okay, for years. Sometimes I would get there as early as 5 o'clock in the morning and stay as late as 12 midnight so that I can make sure that the patient's package, everything was done so the patients could get there. But yes, when they miss appointments, and that's if we know if the appointment was missed or whatever. I just found out recently from one of the nurses that they assigned to my area to help with some of the backlog, which she couldn't believe that I was doing all of this by myself, that to schedule follow-up appointments to help with that.
Okay, so just to clarify, in terms of your position, you are the person who is coordinating the outside appointments?
And I was doing the inside appointments as well, everything.
For the whole hospital?
For the whole hospital.
One person?
One person.
And you just got help?
I got help. Well, I'm gonna tell you when I actually got help. I was out because of my health and my husband's health for a while. And they hadn't had nobody. People was calling me at home saying the place was falling apart because I was not there. Then they hired someone, a young lady, who stayed up about a year. Okay. And then after that, I was back to doing it again by myself and was out. And then when I came back, they brought somebody else in. So it was two of us, but still with the backlog of all the appointments, when I say that it put a lot of patients' health at risk because I did not have the support from the administration. Okay, I wrote several emails in reference to it. I was told before that someone told me there was a meeting held and it was said that, oh, Tony can do it. She can get it all done by herself. No.
Okay. I'm just sort of thinking about the various functions of your job, right? It's the
Okay.
scheduling piece.
Hmm.
You're communicating with transport.
Right.
You're
Mhm.
communicating back to the unit to say, hey.
Yes, we have a
so-and-so.
system that was designed for us to send appointment slips out. Okay, where when we make the appointment, after we make it, it's then sent out through a distribution of a lot of people that I talk to the nurse managers about who should be on this list and who should receive them. Okay.
Okay.
So, and with all the instructions and all of that, and transportation, also get their supervisor who supposedly shared this information with them, that's not always the case.
Yeah, we heard testimony about that, not necessarily always being the case as well.
Mhm.
Okay. It sort of speaks to Ms. Musa's testimony about the clinical system being fragmented. Because, yeah. All right, I don't have any further questions for this group, but thank you so much. Please make sure you provide your written testimony for the record.
Okay.
I just want to telegraph where we're going. So we have three witnesses who are online, and then after that, we'll take a 5-minute break before we go to the government witnesses. For those of you who are online, you have to affirmatively accept our invitation to become a panelist. There'll be a little box that pops up that says, I want to be elevated. So Kate Crossen.
Chair Henderson.
Oh, my bad. I didn't see you, Councilmember Parker.
I would love to ask the panel questions if that's okay.
Oh, yes, absolutely. So we've been joined by Councilmember Zachary Parker, who's a member of this committee, Councilmember from Ward 5. Councilmember Parker, when you're ready.
Thank you, Chair Henderson. And I would say today's testimony has been deeply troubling and unnerving. And I'm looking forward to our government witnesses. But I wanted to follow up quickly with Ms. Clemens. Is it just one person, that person being you now managing the operations for the hospital?
No, I now have a person who is now with me, but she's not in the area with me. She's upstairs where administration sits.
Understood. So I heard your testimony. There's supposed to be 3. So technically now there's 2. And are you still experiencing the issues of backlogging and errors because of not having sufficient capacity?
Yes, and I'm going to say this because, you know, it's so easy for the administration to say that this should be done this time and that time, but they don't really know the whole role of what it consists of getting these appointments. I mean, we go through, when I say I'm sometimes on the phone making one appointment 45 minutes because I have to now address how they're going to get paid. The situations with the patient, okay, oh, we can't accept a letter of financial responsibility. Then I have to go and I have to talk to a supervisor. And then we have it where we don't have all the identifiers when they're asking us questions like, well, what's the address of the patient, okay? And we tell them what they're here at St. Elizabeth Hospital. That's not what we have. And then I go through the thing about, well, we're hospital to hospital. Ma'am, I don't know where you calling from. Y'all phones don't show St. Elizabeth Hospital. You know, this is the kind of stuff.
And I can imagine how frustrating that must be, especially
it's very frustrating.
On the back end, those appointments are missed after you've spent so much time scheduling them.
Yes.
I would imagine then those patients are then being moved to the back of the line, which could be weeks or months down the line.
Yes, the hospital, and when they miss them, they put us on the back burner. I have to literally beg. And when I'm making appointments and when I'm talking to the person, I make light of, how's your day? You know, just to try to break it. And then they know I'm being so nice that I'm trying to get my patients scheduled earlier than what they're trying to give me. So,
understood. What explanation was given for why escort and transportation services were ended?
Well, we had a good escort team, and they was dismantled. They was all sent back to the unit. Okay. And I mean, everything we had, we was taking out 10 patients a day. They were coming back, getting the inside appointments done, but all of that was dismantled and without replacement like it should have been. And they having to use the staff on the units because we lack escorts.
But was there a rationale given for why they were disbanding that unit?
Okay, I'm gonna tell you what was told to me, that it was an individual in the office area that they wanted them to listen to, but these people that was escorts were higher grade than this person, and they was saying that, well, we have Mr. Clemens here, so he's the lead person. Why do we need to take orders from her? And they actually had a meeting in reference to it. Then next thing I know, they was trying to was sending everybody back to the unit because of that.
Understood. And the consequence of that, I would imagine, is if I'm a patient in need of care, I need to figure out a way to get to St. Elizabeth, either through public transportation or other means, which, as you're suggesting, is disrupting the frequency with which patients are making it on time. Is that
Well,
right?
our patients go out only with an escort and our transportation. Now, we used to have our own transportation in the medical clinic, one driver, and they used to when we had hardly no refusals or patients not getting to their appointments.
Got it.
They
Okay, I'm
did
trying to
make the
just
change. When they made the change, all of that fell down because they did not replace the amount of escorts
it.
that we had.
And so what is happening now that you think is the immediate reason why there are so many missed appointments?
Escorts, transportation, because some of our patients have to have a wheelchair van a lot of times, and we only have one. It's not working. Okay. And then so the patient, it gets canceled, or some of the other things is that a lot of patients refuse because
Understood.
yes, they will refuse. And I always put on my appointments that please try to encourage patients to attend.
Okay, last question, just for the sake of time. Can you give me a ballpark of, on a weekly or monthly basis, how many appointments are being missed?
Ooh. Sometimes, okay, we have 5 people on the schedule. Let's say 6 people on the schedule. Maybe 2 or 3 out of that 6 is canceled or refused.
And you're talking, that's weekly?
Oh, no, not weekly. That's daily.
Daily. So an estimate by your understanding is that sometimes nearly half of the appointments could be canceled.
Yes.
Okay, that is helpful. Thank you, and thank you for the time, Chairperson Henderson.
Oh, thank you, Councilmember Parker. Thank you to this panel of witnesses. Like I said, so we're going to go to our virtual witnesses and then we'll take a 5-minute break and we'll come back for government. Kate Crossen, Andrea Poraccino, and Sharice Crawford. All right, Ms. Crossen, when you're ready.
Thank you so much. Can you hear me okay?
Yes.
Excellent. My name is Dr. Kate Crossen. I'm a clinical psychologist at St. Elizabeth's Hospital. Worked at St. Elizabeth's for 18 years. I have always been a member of the DBH Psychologists Union. In the last several years, the district has been consistently losing well-trained, qualified psychologists, and we're having significant difficulties hiring more psychologists back to work in the public sector. Most of the psychologists in the union do work at St. Elizabeth's Hospital, which currently has the highest vacancy rate in the psychology department that has had in the last decade. I think we're about at 30% of our vacancy rate right now, and that's been for about the last 2 years, which means that the current psychologists are tasked to complete all of the things necessary for the safety and security of the patients, but with fewer psychologists doing the work, which creates cycles of delays and burnouts. The primary reason positions have remained vacant for so long is the low salary when compared to psychology positions in other hospitals, organizations. DC, DBH psychologists make significantly less than federal positions, other state hospitals around the area. Our union has collected data to compare the salaries, which show that we're underpaid by several tens of thousands of dollars. In some cases, the maximum salary that a DBH psychologist can make is lower than the starting salary at a local, federal, or other state government in the area. We did begin bargaining our contract with the DC Department of Labor Relations and Collective Bargaining back in January of 2025. But then after setting ground rules, all bargaining was halted and we haven't been allowed to bargain for over a year. So We are understaffed and we can't really fix that unless we're able to pay incoming people the amount of money they can get in other comparable places. So as folks have already mentioned, the pretrial admissions at the hospital have only increased in the past several years. So the need for competency evaluations has increased every year. And while this increase in demand for competency is not isolated to DC at all, it does place significant specific pressure on psychologists because psychologists are the sole providers of competency evaluations at the DC court and the DC jail system, and the majority of the providers for competency evaluations at the hospital. So our staffing vacancies, coupled with the higher rates of pretrial individuals having competency questioned and higher rates of admissions, have significant consequences, where the psychology department are the primary providers of competency restoration groups and individual competency restoration. And sometimes they're the only providers of competency restoration on a treatment unit. So this lack of providers means less services, delayed services for pretrial individuals, which results in forensic pretrial patients staying in the hospital longer than really should be required. Also, directly related to safety, psychologists perform risk assessments for physical violence, sexual violence, which are critical to effectively identifying and then managing patient safety, which impacts safety of the patient, the staff, and the peers on the unit. So psychologists assess short-term risk of violence during hospitalization, as well as long-term risk to determine if individuals are safe to return to the community. These individuals often have serious histories of felony offenses, and psychologists create risk management plans to find a way to get them back into the community safely. And so they can leave an inpatient setting to hopefully transition to a lower level of care. Psychologists are the primary creators of the behavior plans at St. Elizabeth's. I believe Dr. Boyd mentioned functional behavior analysis. We have a team here that does do that. And that process involves collecting behavioral data, creating plans that reduce or eliminate problematic behavior. And these behavior plans are used by the nursing staff and everyone on the unit to help manage often what's a violent behavior and to assist the patient in learning healthy ways of getting their needs met. Psychologists author civil commitment letters used by the Mental Health Commission to determine if individuals are a risk to themselves or to the community due to mental illness, and what level of mandated treatment might be recommended by the court. And of course, lastly but not least, psychologists provide well over half of the individual therapy done here at the hospital and a good amount of the group therapy done as well. And if there are not that many psychologists and we have to primarily put our resources toward this pretrial and these competency things, we have less time for individual therapy, limited availability, which then results in unmet patient needs. So many of these tasks are there to assist the individuals at St. Elizabeth Hospital with their mental health to keep the community safe. And it's really challenging for our wonderful, dedicated, hardworking psychologists to do that when they're overworked, overburdened, and there's just not enough of us. There are units in the hospital that just don't have a psychologist present at all. And several units where are supposed to be 2 psychologists, there's only 1. So that's why we are advocating for for us specifically, our return to bargaining, so that hopefully we can increase our salaries, fill our vacancies, and try to keep the work that we do here going at the hospital.
Thank you. Andrea. Andrea, if you're speaking, you're on mute.
Okay, sorry about that. Hi, my name is Andrea Poraccino. I'm an attorney with Disability Rights DC. Really appreciate the opportunity today to testify before the council. Disability Rights DC is a designated protection and advocacy program for people with disabilities in the district. My testimony today is going to be focusing mostly on the seclusion and restraint issue. For far too long, St. Elizabeth's has been subjecting patients to the trauma of being physically restrained, strapped down to a bed, or secluded alone in a locked room. Just as traumatizing, restraint and seclusion are often accompanied by involuntary injection of chemical restraint. Now, restraint and seclusion should be a rare occurrence. State and federal laws allow their use only in an extreme emergency when all other forms of de-escalation have failed. And these restrictions are there for a good reason. Restraint and seclusion can produce high levels of distress, fear, and anxiety in both patients and the staff, and cause re-traumatization of those who have experienced physical or sexual abuse. And research shows that seclusion and restraint are not effective and can actually fuel violence, creating a vicious cycle where restraint and seclusion can cause, reinforce, and maintain aggression and violence on the wards. Our concerns we've made public in several reports and on testimonies before this council continue unabated. And restraint cannot be a routine practice. It's not treatment, and it's not the answer to the violence on the units. DBH reports the St. Elizabeth Hospital stats every month in their prison reports, and these numbers speak for themselves. Staff employed restraint on an average of 72 times a month in 2025, which averages to over 2 a day. Although they employ seclusion at lower rates, these rates are high, averaging 24 incidents a month. Equally alarming is the number of stat or medication injections, which is a shocking average of 50 events a day. Now, with Disability Rights DC's urging several years ago, St. Elizabeth agreed to address the same problem, to contract with a nationally recognized expert consultant to implement a program at St. Elizabeth's based on violence prevention strategies and trauma-informed care techniques. She's been able to begin her work. However, the hospital administration and DBH needs to prioritize her work and ensure her programs are implemented hospital-wide. The solution starts at the top. St. Elizabeth's administration frequently insists their restraint and seclusion numbers are close to the national average. For the 570 patients who were either physically held, locked alone in a room, and the patients involved in 604 incidents of involuntary medication from January 2025 through November 25, these statistics are not a consolation and do not help them heal. Since the average daily census is 264 patients, these numbers are clearly concerning. All the leadership, nursing, medical, psychiatric, forensic, and other administration staff must buy into these violent prevention and trauma-informed care strategies, which had been proven effective to reduce restraint and seclusion. The status quo cannot continue. And I'd just like to echo, hearing this testimony from the staff is obviously very concerning. And these kinds of programs not only work with staff, but they also not only work with patients, they do work with staff. They're generally very well accepted by both staff and patients. They have a contract, and it just needs to be implemented. And this would be one very effective way to reduce the violence and prevent the violence on the units. And thank you for the opportunity to testify.
Thank you. Thank you for your testimony. I do have a couple of follow-up questions. I'm not sure if Councilmember Parker is still with us right now. There is another hearing going on, several hearings going on. So I don't want folks to think that my colleagues don't necessarily find this important, but there are lots of competing issues going on today. Dr. Crossen, I wanted to ask, you outlined in your testimony all the various things for which, psychologists on staff are responsible for. And one of the things you talked about was the treatment plan. Is that
behavior plans.
The behavior plans.
Mm-hmm.
But in sort of thinking about, I guess what someone also said earlier around like the fragmented clinical pieces here, it is entirely possible that you or one of your fellow colleagues could say, as part of the treatment plan, we think that patient A needs to go to PT. And then that order goes to Miss Clemens, and Miss Clemens is like, okay, I could try to get it scheduled, but I don't know if I have transport to get that person there. And then, so I guess my question is in terms of, have you guys ever sort of looked to evaluate the efficacy to which your treatment plans are able to be followed due to other systemic issues within the hospital?
Yes. So when we do behavior plans, it's usually, to your point, like with a whole team of people, and we are but one small part of the total. And the behavior plans like that, like for example, the one that Dr. Boyd mentioned about taking the gentleman for a walk so he doesn't hurt people.
Yeah.
That kind of thing we do all the time here. And it's created with nursing staff, and then nursing staff is trained in how to do this. Like what's our idea? What are we going to try? But if the nursing staff is short and somebody had to go on an escort duty because there wasn't an escort, and so no one can take this guy for the walk he's supposed to have, then we accumulate the data of what preventative measures were done, why, if they weren't done, why not? Because nursing staff, I'm sure several folks there in the audience will tell you, they've had to fill out those kind of shift reports for folks who have active behavior plans to say, hey, here's the preventative measures that we all talked about that we think are going to be helpful. Here's what we were able to try today. Here's, what worked and what didn't work. And we do that so we can track efficacy, right? To see what works. And so when the barrier is systemic, because it's a lack of supplies, because for some people, taking a break in coloring is something that, they can do, but it doesn't even require much staff to help them with that. But we don't have coloring materials, right? We don't have markers. So we need supplies and staff, obviously, to carry out these behavior plans. And so when that's not available, then we just have to figure out what else to do, which again is more challenging to figure out workarounds, which I think several people have mentioned, just systemic workarounds we've all been trying to do. If we don't have A, B, and C, then now we're down to D, E, and F, and how do we make that work as best we can?
Yeah. Well, so you've been at St. Elizabeth's for 18 years that you said in your testimony. I'm curious, in terms of the testimony, whether it be from PDS or even from the nurses, et cetera, about what's happening, St. Elizabeth's sounds less like a hospital and more like a jail. And I wonder if that was the case when the population was different, right? When there wasn't such a large forensic population. Was it different, or is this a result of the changing population where the administration is sort of not thinking about it from the perspective of how do we help people, but rather they're here for some other sort of criminal behavior?
So as a psychologist, obviously, everything is existing in context, and there's so many things that are happening. There is a well-documented forensification of the mental health system. Our patients that we have here at the hospital are more forensic than they've ever been and more pretrial than they've ever been. So when I started here, I actually started here when when we were still under DOJ receivership. So that was different. Yeah. and there was a lot of psychologists came on staff in response to that. And then we've lost some of that number, and I hope to get it back because it was something that helped, and it was something that the DOJ receivership suggested that we do, was have more psychologists to do risk evaluations and behavior plans and things like that. But when I started here, I worked on civil admissions, and frankly, there hardly is a civil admissions at all anymore. It's a half of a pretrial unit now. So when this community members who are in need of mental health care just need help, this is not the place for them. There's no room for them here, unless they get arrested, and then they're sent here for competency or sent here in some other way. But I think several folks have mentioned this is a hard place to try to just get treatment and leave, because our beds are immediately taken up. Like the gentleman from 1F said, the beds are immediately, there's a waiting list from the pretrial services to get people here. And then how soon we can get them competent and get them back to where they need to go is incredibly variable.
Yeah. There's sort of a lot to unpack there, but it does beg the question of, if I'm a person in the community and I can't afford private care, but I need help, I have to get arrested before I get that. And whether or not, okay. Ms. Poraccino, I wanted to ask about restraint and seclusion, which is a little bit of what Ms. Boyd brought up, and maybe Dr. Crossen, Dr. Boyd, and maybe Dr. Crossen, you might have some information on this as well. We didn't ask in the pre-hearing questions about the use of seclusion and restraint, but I would imagine that there has to be some sort of documentation, particularly if a chemical restraint is used. Correct?
Yes, they have to fill out, staff has to fill out a major unusual incident reports. And like I said, they do publish every month their statistics online of how many restraint and seclusions are used per month. And that's where I got my statistics. So like I said, it's averaging about 2 a day. according to their own numbers.
Yeah. The thing is, what I've now sort of learned is even when staff have to do a report, if you're emailing it to an inbox, what is happening with that data, what's happening with that information, and that's kind of a bigger issue. And actually, let me ask the follow-up to Dr. Crossen. You said that staff have to document when they weren't able to meet the letter of a behavioral treatment plan due to some particular reason. How often is that information sort of audited?
It's more of an internal document so that we can shift the plan, like if that makes sense. So we have a great positive behavior support team who work on behavior plans, track them. The psychologists on every unit can do them too, and then if they're not working, if I try to do one and I'm hitting a wall, I elevate it to our positive behavioral support team. And I can follow up with them and see if they have some data on that. But again, it's more for us. We want to make the situation better in the moment, in the now.
Yeah, no, I appreciate that.
Right. So a lot of our data is meant to then pivot the plan. So, okay, these supplies aren't here. This was our first plan. We don't have it. So let's see what else we can do.
And I appreciate the part of you all trying to sort of act in real time in the best interest of the patient and sort of trying to make it work for the unit. But when the systemic issues don't get reported, right? If, I don't know, 70% of the time your behavioral treatment plan can't work because of staffing, that should probably be reported.
And I am going to say that I imagine this is me needing more information, because I imagine that those are the discussions that our positive behavior support team staff probably have more regularly on a daily basis with other, with admin staff, with management, to say, hey, here's what we're trying to do. Here's the barriers to doing it. And it's, there's, as folks have said in this hearing, there's a lot of kind of systemic issues and understaffing issues that need to be addressed. So it feels like sometimes it's a drop in the bucket. But I can find out and encourage them to pass along whatever information they have to the council.
That'd be great. All right. I don't have any further questions for both of you, but if you could provide your written testimony for the record, that'd be helpful. We're going to take a 6-minute break, use the restroom, et cetera. And then
Chair Henderson.
Oh, my bad. You're not on camera, Councilmember Parker. I'm sorry, Dr. Crossen, if you're still there, and Ms. Poraccino, Councilmember Parker is still with us. Send a text.
It's all good. It's all good. Sorry about that. Ms. Crossen, I wanted to follow up. For the units that do not have psychologists, do the patients in that unit still have access to behavioral plans if needed? And how is that managed, if so?
So while they don't have a psychologist on the team, then they have clinical administrator, social worker, psychiatrist, and there is a point person in the department to respond to inquiries, questions. If someone's in need of a referral, then the team has a person to go to. And so that we can still generate, if someone's saying, hey, we're having a problem, we think we need a behavior plan for this guy, then they can reach out. It's just a matter of, it's a bit of a delay, and then it would require other people to kind of remember what we do, remember the things that we have to offer as a department, think of them independently and ask for them, rather than having a person there kind of thinking more proactively and being present to do it right away. So it is there is a person who can respond to the needs of the unit, but it would take longer. And then it would probably go straight to the positive behavior support team to do, instead of starting with, there's no unit psychologist to start the process. Because sometimes a behavior plan can work and it's kind of simple. It's like, hey, let's take this guy on a walk every day, problem solved, done. And we don't need to keep doing more or escalating or making it more complicated than that. And that's where I come in as a unit psychologist. And then when it gets kind of beyond my scope, I'm unfortunately not an expert on the PBS team. They have folks assigned to every unit though too, and they're always communicating with every unit as a umbrella group. So
Understood.
there's always
then-
someone there to help.
And then you mentioned in passing that you're seeing an uptick in pretrial patients. Do you have like more concrete stats, or can you speak to specific numbers that you're noticing?
I don't have them personally. I know the hospital does. Like I know other people have them, so I don't want to misspeak, but I know that we have that information. I also know that the admissions, the civil admissions unit, which should have 25, 26 beds, about half of that is dedicated to pre-trauma, which is an increase. Other units that we had as step-down units, like for longer term patients, have been converted also to pretrial. So there used to be 2 all-male pretrial units and 1 female pretrial unit. And now we've got 5.5. So there used to be 3, and now we have 5.5 pretrial units. So
Wow.
it's clearly increased. I just don't know the exact numbers. I know it's the graphs I've seen.
And how many people are housed per unit?
Between 25 to 27.
Wow. Okay. That is helpful. And then Ms. Poraccino, I wanted to come and, staggering numbers, and we've heard about these medical restraints. I share your concern about the trends that you reference. Again, noting 570 patients were either physically held or locked in a room, 604 incidents of involuntary injections or medications. You mentioned in your testimony that there are measures that have started to reduce these levels of restraint and seclusion. Are these measures that are being shared with staff or psychologists through training that you're aware of? And or what other recommendations would you have for how we can push for a reduction in these levels?
Yeah, I'm really glad you asked me that. So when we started to look at this years ago, we've published public reports and we just haven't seen the numbers drop. And seclusion and restraint does reflect violence on the unit. Like you're not going to restrain someone if they're not just aggressive behavior. So we recommended a national expert from SAMHSA. Her name's Joan Galise, and they agreed to contract with her. And she's also works in the DC jails. So she's familiar with forensic populations, and she has an approach which is violence prevention, trauma-informed care. However, in order to be effective, the administration has to really buy in. Her approach is not just one training and then she leaves. Her approach is to come in every week. That's what she'd like to do, come in every week. She'd like to really get to know the staff. Then she has groups with the patients to talk about strategies and their trauma. She talks to the staff about their trauma, and staff really, general that I've heard, really like her. The patients like her. And what the kind of work she does has been proven to really help with the violence. Now, of course, if you don't have the nurses and staff to implement it, it makes it harder, but there's no reason this can't be addressed along in conjunction with addressing the short staffing. I mean, it's just a win-win for everybody. They already have a contract with her. I'm not sure she's been contracted for years, and I'm not sure what the holdup is that she can't get in there like she wants to. And I think, if it's a matter of money, you're going to save so much money in the end if you can reduce this violence. So it just seems to me it's an investment worth investing in.
Okay, thank you. I will be sure to follow up on that. And thank you for your testimony.
Sure.
Okay, thank you, Councilmember Parker. Ashley's going to put 6 minutes on the clock and then we'll be back. Thank you.
Great job. Yeah.
I'm here. Whenever I did, jump in. She's stuck with you. I saw. Yes. Thank you. Yeah, I talked to him earlier, yeah. Yeah, I talked to him earlier. I'm good, how you doing? Good to see you too. Yeah. Yeah. I'm not even saying my bed. Yeah, I was just in my bed on.
Okay, and we are back with our government witnesses. Now, Dr. Basron, I have that you were presenting the testimony. Is that
Correct.
correct?
That's
Okay.
correct.
I need to swear you all in. So this is how I do it. So it doesn't interrupt the flow. So it is everyone who is might speak. So if you might get called to the table, tapped in, phone a friend, raise your right hand. Okay. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. All right, Dr. Basron, when you're ready.
Good morning, Chair Henderson, committee members, and council staff. I'm Dr. Barbara J. Basron, Director of the Department of Behavioral Health, or DBH, and with me is Mr. Mark Chastain, the Chief Executive Officer of St. Elizabeth's Hospital, the district's inpatient psychiatric hospital. We are here to discuss the operational challenges at St. Elizabeth's Hospital, our progress in resolving them, and our plan to continue progress. Under the leadership of Mayor Bowser, DBH supports healthier and stronger communities by working to prevent the onset of mental health and substance use disorders and providing a range of community-based treatment services and recovery supports. DBH also provides crisis services and operates adult and child urgent care clinics. I want to start my remarks by thanking the 725 employees at St. Elizabeth's Hospital. I am committed to making sure that they have the resources and supports they need to do their jobs. I heard the testimony of employees and their union representatives today about operational and safety issues and recognize that some of their complaints are longstanding. As Mr. Chastain and I reported to the leaders of the DCNA and AFSCME, we are systematically chipping away at these deficiencies and will continue to make progress. Deputy Mayor Wayne Turnage also attended the meeting and offered to meet with the union leaders every 3 weeks to address not just the specific issues, but also how management can better support our shared goal of a work culture of open communication, support by managers for each employee, individual accountability, and safety. We responded to the list of pre-hearing questions that address staff hiring and retention, safety, and operational issues that affect our ability to deliver quality patient care. Mr. Chastain will talk in more detail about this, but I want to share progress we have made to address these areas. Regarding nursing staff, we have talked about the external factors that affect hiring and retention, including a competitive market. The hospital also is facing a changing demographic in its workforce. Retirement accounts for nearly 30% of the departures in our nursing staff since 2023. In addition, 59 or 8% of employees are using the family and personal benefits to care for themselves or loved ones. Despite these challenges, there are 162 nurses on board and 10 new nurses are in the pipeline to hire within the coming weeks. We are recruiting another 16 nurses. There are 162 behavioral health technicians and 3 outstanding offers and another 13 in recruitment. The district offers a generous benefit package. We have a 12-hour work schedule for nurses and competitive salaries. Excuse me, the turnover rate for registered nurses is well below the national standard. Our challenge is to make the work environment as attractive as possible and look at other ways to encourage retention. Our approach to maintaining safety at St. Elizabeth is to develop and implement, a comprehensive plan that includes, sorry, sorry about that. That includes anticipation.
Sorry, take a moment.
Okay.
Yeah, you know, we've got a room full of nurses. Is everybody behind you ready to hop into action?
Ready to jump in. Sorry about that. Something happened. Okay. All right. Sorry for the interruption. The turnover rate for registered nurses is well below the national standard. Our challenge is to make the work environment as attractive as possible and look at other ways to encourage retention. Our approach to maintaining safety at St. Elizabeth is to develop and implement a comprehensive plan that includes anticipation and planning for aggressive or violent incidents, since we serve patients whose illness increase the risk of harm to themselves, other patients, and staff. The element of our safety plan include training for staff on safety, de-escalation techniques, reporting of incidents, and zero tolerance for patient abuse. Patient-centered, recovery-oriented, trauma-informed care. And this is the process that Ms. Poraccino was talking about earlier, and the contract that we have in place. A physical environment that supports therapeutic care and use of safety measures and security for or safety officers. We expect to discuss these elements with the committee in more detail. Regarding supplies and maintenance issues, in addition to normal wear and tear, our hospital facility is now at the 15-year mark and showing its age. However, some of the issues identified by employees took much longer to address than they should have. As we shared with the union, we are making progress by purchasing new equipment. All patient units now have new glucometers and supplies. Addressing the supply issue with daily monitoring and new staff to manage inventory. We acknowledge that this manual process is time-consuming and inefficient, and our goal remains to purchase an automated inventory management system. Moving forward with hiring a new manager for supplies and cleanliness after the retirement of a key staff member, and investing $1.5 million to replace worn-out furniture, including staff chairs and medical beds for patients. A new paging system is operational, which allows for more audible alerts to staff when incidents occur on patient units. We are systematically addressing these issues and expect to see continued progress. I want to conclude my testimony by reiterating the offer to meet with union leaders on a regular schedule to address these issues. Thank you, Chairperson Henderson, and we are ready to answer your questions.
All right. Thank you, Dr. Basron. And we're going to jump into questions. We're going to do 2-minute rounds. I'm going to keep an eye on my staff because several colleagues have asked for links, so they might be joining us virtually. And I do believe that Councilmember Crawford is going to come back. So I'm going to, is Councilmember Parker here? Okay, so we're going to start with the clock just in case. So if we want to start on 10-minute. All right. Thank you all for being here. Are you okay? Do you need a moment?
I'll be okay.
Okay. All right. There's a lot to discuss, and there are a lot of things that were sort of covered here, but I want to do some I want to start on staffing and do some follow-up questions there. Dr. Basron, we met December 8th to talk about St. Elizabeth's Hospital. And at the time, the hospital had 90 vacancies. So that was December 8th. 6 were clinical psychologist positions, 20 psychiatric nurses, 16 behavioral health techs. Some of these positions were frozen, but have since been unfrozen, or hopefully they have been unfrozen. So I want to get an update on that. What's the current number of vacancies right now?
Do you have that, Mark?
Approximately 82.
82. You got to use your mic, Mr. Chastain.
Yes, can you hear me now?
Yes, sir.
Approximately 82.
82. Okay.
Madam Chair, would it be appropriate at this time to introduce some of the members of the team who will be joining to respond to your questions?
It is actually better if they introduce themselves if they were going to respond to the question at the time.
All right.
Because I'm good, but I'm not that good to commit it to memory.
Okay.
at the top. How many clinical psychologist positions are vacant?
I think 6 at this time.
Still 6. Okay. In terms of the positions that were frozen, the psychiatric nurses and the behavioral health techs, have you all been successful in getting those unfrozen? I mean, it's a new fiscal year, so they should be available to you.
Yes.
Okay. So, how many psychiatric nurses are we, vacant at the moment?
Now, I want to be precise. I think 17, but let me ask Ms. Marty Pontes, the Chief Nursing Officer, if she would join us. If we
Okay.
Go, you there?
All right. If you could just introduce yourself for the record.
Yeah, there are 26 nursing nurses that are vacant right now, FTEs.
Okay. But, can you introduce yourself for the record?
My name is Martha Ponce, Pontes.
Ponce, P. Okay. It's Ponce. Ms. Ponce, of the 26 nursing staff that's vacant, how many of those are, I mean, do you distinguish between the psychiatric nurses versus regular RNs?
We only hire psych nurses.
I'm sorry.
We're only hiring psych nurses.
Okay, so the 26 that are vacant is encompassing all?
Yes.
Okay. And Mr. Chastain, how many behavioral health techs?
They also report to Ms. Pons.
Okay.
Go
And
ahead.
there are 18 vacants.
18. Okay. So, Dr. Basron, in your testimony, you talked about recruitment. Now I recognize that the market is very tough in terms of recruitment. I met yesterday with the interim CEO for Cedar Hill, as well as the president of George Washington University Hospital. So I'm familiar in terms of the workforce challenges, but there are ways and methods for which we can make ourselves more competitive or not. So what's our approach here in terms of recruitment?
Well, first of all, one of the things that I will say is that we do have a good benefits package for the district. And we also have allow for 12-hour work opportunities. And also we post positions and are going through the recruitment process. And I think some of the benefits that are available within the district do attract individuals here.
Mhm.
And so we're hoping that that will work. There may be other things that Mr. Chastain has in place that he can talk about.
Okay.
I'd like, before I comment, Ms. Pons.
Okay, Ms. Pons?
We do have a very active recruitment process going.
They can't hear you.
If you want to lean in, you got to
Can't
hug it
hear
just a
you.
little bit. These mics are fickle.
Yeah.
Can you hear me now?
Yes, ma'am.
Okay. We have a very active recruitment process. It's ongoing right now. They just posted 20 positions as far as the RNs are concerned. Those just within the last few days. And they posted 10 BHT positions. Those were posted last evening. We have several folks that have questioned if we have openings. We're telling them by all means, check the website because they do have to apply that way. Once they apply direct with their resume is actually reviewed downtown, then we receive a certification form up to the hospital.
Mhm.
And we immediately will start making appointments for them to come in to be able to do face-to-face interviews.
So you guys manage the hiring, not DCHR?
We manage the interviewing and the selection. Then HR will take over as far as doing the background checks and all the other.
No, Councilmember Henderson, we have independent hiring authority.
Okay, that was my
That's
question is,
correct.
Okay.
DCHR is good at some
Yeah.
things, but when you're managing the hiring for the entire government, some things don't get prioritized in the way that perhaps they should be. Let me ask this question around then the questions around overtime. And I was trying to, I saw your AFO and then he disappeared. I need him to come on back. Adrian, if you're around, but, there was a question, I think Councilmember Crawford had asked, do you have mandatory overtime? The response was no, technically in the collective bargaining, you don't. However, a nurse can't leave unless they're being relieved. So therefore there is in some ways mandatory overtime by the sheer fact of like, you can't just clock out when your shift is complete.
Correct.
What's a major driving factor in terms of overtime?
One, the lack of staffing. We also have a fairly good attrition rate that's occurred recently with regards to folks retiring. There are folks who also do not want to work on certain units and won't go there. But it's primarily a basic staffing issue of having appropriate or qualified available people.
Okay. All right. Now nursing is only one part. We also heard some challenges in terms of escorts and transportation. I imagine that doesn't fall under you, Ms. Pons.
Part of it does.
Okay, which part?
The escorts.
Okay.
The escorts do fall under me. They are BHTs. We do have, at the present time, we now have 6 folks that work in the escort department. They are working primarily from 6:30 in the morning until whenever the last appointment ends in the day. They do take the individuals in care for appointments in the hospital. They also will take them on appointments out into the community.
Yep.
It depends upon the individual, how many people have to go with them. That will make a difference regarding the person's legal status. Sometimes you have to have 2 people go rather than just 1.
So when you all are making these sort of decisions around staffing, right? I think we talked about, the schedule has to be out by a certain period of time to know which, where, and the other. Is that information also being shared with the medical clinic team who is scheduling these appointments? Because if, let's say, for instance, you have a person who needs 2 people, given whatever their particular status is, but you have 5 escorts on the schedule for that day, you're already down.
The medical clinic does not necessarily know what the person's legal status is or the person's elopement risk is.
Okay.
Or those items that we have to take into account when we're actually having an individual go out. That generally gets taken care of more in the morning. Sometimes we will be able to send 2 escorts staff with that patient, depending upon what the rest of the load is like. Otherwise, you would take 1 escort and a staff member from the unit. But we do try to make sure that the appointments get taken care of.
The escort is not the person who's driving, correct?
No, that is with transportation.
Right.
That is under another individual, but when the listing goes out from the medical appointment area, there's a full Excel spreadsheet that goes out to transport, and it has listed down as to who's going to be the driver, who's the person who's going, where they're going, and you get some of the time frame for when they need to go out.
Okay, I'm over my time, but I'm gonna come back to this because what I'm trying to get at here is this issue of if one side talking to the other. If a person doesn't know, like, let's say I'm the one who's scheduling, I'm like, okay, great. We got 6 escorts on the schedule. I can move around X number of patients. But when in fact, I don't know that one patient requires 2 escorts, then my schedule is already messed up because, from the very beginning, because I just didn't have enough information to know of the number of available bodies I have, which just feels like a internal communication structural issue that should be very easy to solve if y'all just one department talk to the other. But I'm over my time. Oh, nobody's here. Oh, great. We can continue to unpack it. So this seems to be very much an issue that has come up on the frontline staff. How does the issues rise up to the point of a supervisor or a manager saying, hey, this is not working?
It will rise up to the manager's level when the individual comes back or when when you find out the appointment has not been held or it has to be rescheduled. And generally it's the manager or somebody on the nursing group that will actually make the initial call. And early in the morning, I'm the one that's going to get the call from the escort team because I'm in there at that hour of the morning, letting me know that either there's not a driver, this person, they don't have sufficient people scheduled, and then it's up to me to work and try to get it set up.
Okay. I know some of it's planning ahead and some of it is people call out.
Yep.
Emergencies happen, etc. Do we normally set the schedule for the week and then make adjustments daily? Or is it a day by day? Let's see.
As far as the appointments are concerned, we've tried to get really a weekly schedule, but wait a minute. They'll make the schedule weekly in the database system. However, it gets printed down on a daily basis for the appointments going out. As far as the staff, there is a set staff that is listed out on the placement sheet. So you know who's going to be in the escort unit that day.
Okay. Who is responsible for tracking whether or not an appointment occurred or not?
It probably fall more under the medical clinic if they have to make a reappointment, but the notification will go to the nurse on the unit. It will also go to the physician on the unit who made the request for the appointment.
Okay. Would it go to like a chief clinical officer or a chief medical officer? I'm trying to understand who's auditing to see. Because there seems to be like.
It could very well.
If you
It would be something.
Yeah.
Yeah. That sort of, those breaches of protocols and policy, we've tracked those and I would ask in our meetings, why do we have so many cancellations? And the typical reasons are patient refuses to go. Some of the, excuse me, please, respectful of each other.
Guys, if y'all could, thank you.
And so we do track exceptions, circumstances that didn't go as we intended. And this would be one area where we would do that. We have committee meetings that do that. We do it with assaults. We do it with all of the major incidents, et cetera.
How often are you tracking that an appointment did not occur?
Quarterly.
Okay, so
I ask about it frequently.
if I'm a patient and I'm a patient at St. Elizabeth's Hospital and part of my treatment plan is I'm supposed to go out for, I don't know, PT. Nobody's checking except for quarterly of whether or not I went every week.
Yeah. So it would be brought to my attention a number of ways, or leadership's attention in a number of ways. Or the manager assigned to this area. Every patient activity has a manager assigned to make sure that it proceeds as planned. When there are exceptions, that's noted, and there's follow-up on every case where patient services are required for patient care and treatment.
When's the last time you guys did an audit to look at how many appointments are being missed due to staffing or transportation issues?
I don't have the numbers in front of me, but I do know that the supervisor within the escort team itself does keep track of that, does look at that.
Okay.
So what pops to mind, excuse me.
Go ahead.
So it would be noted in a number of forums. So DC Health comes in and does a review of patient activity, and they may note it, that a patient missed their appointment. So we would look into it as a response to that kind of an inquiry. The DC Health visit, annual survey visit, where they would make a note of it, and it would be a citation.
But that is
that we would have to
annual,
follow.
Mr. Chastity.
No, I'm just saying, it comes up in a number of ways over time. And that would be one of a number of ways that we would follow up and determine whether or not there is a problem. This is fresh in my mind because we have followed up with our chief medical officer, Dr. Wilson, who has been, this has been discussed with him. So Dr. Candelas is here as our chief medical officer. He and I would discuss it in our weekly meetings. He would talk to Dr. Wilson. Dr. Wilson, the chief medical officer, Dr. Candelas is a psychiatrist. He is a chief medical officer and internist who would deal with these kind of matters. And we would follow up and make sure that there's compliance with consultations and other services ordered for that patient's care and treatment plan. There's ongoing continuous monitoring of patient services.
I understand. I'm not
Is-
saying, I'm not suggesting that there is not ongoing monitoring. What I'm trying to say is that there does seem to be, if you're doing it in a one-off basis, then we're
No.
not addressing the systemic problem.
Yes.
But I think this quota gets to, and we'll talk about inventory and those kinds of things, but like, if you were asked today to run a report of how many appointments were missed this week, could you do that?
Yes.
Could you do that, Ms. Pons?
Yeah. Yes.
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 Okay, so let's do an exercise.
I would walk next door, and there's a person I would ask, and I ask her periodically, how are we doing for medical appointments? And she says, we're doing much better. I ask, what does that mean? She says, we are a week behind, or whatever it might be. If it strikes me with 40 years of experience doing this sort of thing as unacceptable, I will dig deeper. I'll go right down the hall and talk to the chief medical officer, Dr. Wilson, which I do frequently on all kinds of issues. So we have committees, we have data, we have these kinds of interactions between staff to make sure that we're giving good care and treatment.
Okay, so this is what I'm gonna ask, because I know you have people here, but there's somebody back at the hospital on the computer who's also listening. Ask someone to run the report for January 1 to today of how many appointments were missed due to staffing or transportation, not patient refusal. I'm going to guess that you're going to tell me you don't disaggregate the data.
No. Maybe I won't. We'll find out together.
Okay.
I will. Are you asking me to text now?
Yeah.
Mr. Tanasia, would you do that?
Percentage of
And-
appointments missed
Yeah.
due to staffing or transportation.
I'm not
Because-
sure go ahead. Go ahead.
Because when I asked you, what's the reason why, you anecdotally will tell me patient refused to go. But the data will tell you, is it the patient or is it the infrastructure?
Yes.
Okay, all right, we'll come back to that.
Jillian, if you would.
All right, let's turn to psychologist. So Dr. Basron, you and I have talked about this. I know that some of this is outside of your control and your purview, but what conversations are you having with the mayor's office, the city administrator, and the labor and bargaining team about getting this particular contract back to the table of negotiation?
I have spoken to Director Hall regarding the fact that the psychologist salary are lower than what is expected out in the community. It is a part of the collective bargaining process, which really is in his realm of responsibility. We do not independently negotiate those contracts, but we do give input.
Right.
So I've been doing, yeah.
I mean, I've had this conversation with the CA of like this, they got to figure it out. We got to get back in the pool. And I recognize that there's what exists in the workforce investment account. Okay. But in terms of, I think of this as a critical staff position, because if you don't have psychologists to do the competency, then you don't, delay justice on the public safety side. So like, we got to treat this in the same way that we treat sort of the recruitment of police officers around here, right? In my opinion, on that front. Okay. What's that? Oh, okay. We've been joined by Councilmember Charles Allen. who's a member of this committee. Councilmember Allen, I'm happy to turn to you as opposed to you waiting 10 minutes.
Oh, I appreciate that. I just hopped on, so I didn't know if you were mid-question.
Oh, no. We'll be here. Go ahead, Councilmember Allen.
All right. Well, first off, I want to thank you to Chair Henderson for holding today's oversight hearing on the operational safety concerns at St. Elizabeth's Hospital. My staff and I have been tuning into the hearing this morning to hear some of the testimony. I got to say, I am concerned about where we are today with the operational and safety challenges of the hospital. Some of those challenges have been around for a very long time. So I'm appreciative of the efforts of yourself to conduct oversight over the hospital, help push the executive to course correct where needed, and get the hospital on a path to success. I do appreciate, that I think I heard kind of a tone from Dr. Basron that they acknowledge there are problems at the hospital. So I appreciate that, but I also want to make sure we're seeing urgency to fix these problems and let kind of this oversight hearing, kind of let it help light a fire for everybody. And the council is going to keep pushing. So I did have a few questions, Dr. Basron, if I could use my time for that. One of the things that concerned me earlier today, we heard testimony specifically from Hans Thomas, who talked about increasing physical violence at St. E's. I think he said that physical violence at the facility had increased about 55% year over year. What do you attribute the increase in physical violence to? I guess, first off, do you agree with that characterization? But also, what would you attribute the physical violence increase to?
I think that I can begin and the CEO can certainly respond. But one of the things that we are seeing, as you know, and it's not only here within the District of Columbia, but across the country, is an increased number of people who, forensic patients who are coming in for competency evaluation and competency restoration. So I think that's something that we're seeing, nationwide. The CEO can talk specifically about what he's seeing.
Yes. So good afternoon. One of the things that we have to keep in mind when we're looking at that data of 23, 24 and 24 were COVID years. 20, 21, 22, 23, and 24. We redesigned the hospital to respond to the COVID pandemic and emergency. We reduced census. So the average census during 20, 21, 22, 23, and part of 24, the census was approximately 200 inpatients. Today, it's 270, between 265, 270 on average. So it's 30%, the census is 30% higher. That's one major factor. The second major factor is that forensic admissions constitute approximately 95% of all admissions to the hospital. So forensic admissions have escalated in an extraordinary way. Part of that is because the jail census is 100% greater. And we have two experts here who for forensic services we're going to hear from shortly to confirm that number. The jail census has gone up approximately 100% from a year ago. And so those are two factors that we have to keep in mind when we analyze what's happened over the last 3 or 4 years with assaults. We don't refer to it as violence as such, but assaults. What we do—
I'm going to go ahead and go out there and say an assault is violent. Well, let me ask.
It doesn't have to be. Yes, go ahead, sir.
Okay, well.
All too frequently it is, but go ahead.
Yeah. So patient census going up, that certainly could account for part of it. And I also hear you saying the nature of that census increase could be a factor as well. Does St. E's perform an investigation like on each case of physical violence or an assault, regardless of its patient on patient, staff on patient, vice versa? Does every single one have an investigation, or is it only certain category of an assault would reach to a investigation standpoint?
There is follow-up on every one of the incidents, assaultive incidents. a incident report is completed by the staff involved. And then that is compiled by a data analyst. It goes into a report we refer to as PRISM, and a committee reviews that data every 2 weeks in great detail. Patient on staff assaults, patient on patient assaults. We have a system called eRisk where that data is compiled and analyzed, and we look at it every 2 weeks at a minimum. I chair the assault committee. It's a multidisciplinary committee comprised of labor, clinicians, administrative personnel, and we review it and we follow up on a number of major initiatives. I'm going to share a couple of those with the committee in just a few minutes when it's appropriate, Madam Chair. That'll shed light on some major initiatives we're undertaking to address physical violence and assaults at St. Elizabeth Hospital.
Okay, I look forward to hearing that as well. So if we're categorizing the assaults and then you're having those incident reports and they're reviewed, can you help us understand then what's the breakdown, for example, of patient on patient versus patient on staff?
So we don't track it that way. I can
That's
go
not a
into
part of the
our
incident report?
Data. Go ahead, sir. Go ahead.
Sorry, I know there's a lag sometimes online, so I apologize. Is that not part of the incident report?
We don't track that metric that way. We track 24 different metrics, but that's not one. We can create a metric if that's the pleasure of the committee to track that going forward and come back and share that information with you.
Okay. I mean, I think it'd be helpful for the committee, but I think it's also helpful for you because obviously your intervention strategies would be perhaps different for a patient on patient than a patient on staff.
Take them
I'd
all
recommend you do that.
Yes, we take them all very seriously and we follow up.
I know my time's going to tick down pretty fast. Let me get to one other topic. One of the things that we heard or we saw in the written testimony from the Public Defender Service had to do with issues around meals. PDS testified many of its clients report meals typically consist of white bread, white pasta, potatoes, and meat that their clients described as having an abnormal taste. Clients apparently have had significant weight gain, developed diabetes, hypertension, sleep apnea. Those clients that are vegetarian or vegan haven't been able to get those types of meals. And I'll just say it feels pretty similar to some of the issues that we have seen historically at the DC jail. Who's the contractor that provides and prepares the meals at St. Elizabeth's?
They're prepared in-house. Food is medicine at St. Elizabeth Hospital. A dietitian does an evaluation of each patient. It's part of their treatment plan. Many of the patients' common complaints include there's not enough. I want more. I want more sugar. I want more salt in it. I want, things that are not particularly healthy. So it is based on their clinical needs. Marty, do you want to add something else to how we?
Well, one of the other things I would add when she speaks about the issue of individuals gaining weight is that many of the medications that our individuals in care are on actually do in fact cause them to gain weight. And that's one of the reasons why they might be saying, I need more food. Because we have to be able to control it in some way. But they do get a balanced diet.
Okay. So the meal preparation is done in-house with staff, not contracted out.
Correct.
Okay.
The only exception when that's not true is we had a fire in July of 2025, and we did have catered meals for a short period of 120 days approximately. We are now back operational in-house.
Okay. So when PDS or anybody says that the meal is not from a health and nutrition perspective, so I'm not talking about somebody that wants a little more sugar, a little more salt, but they're describing the meal as white bread, white pasta, potatoes not balanced or dissatisfactory, from the standpoint of what the protein may be, or someone that comes in as a vegetarian or a vegan and needs to have a very specific meal, and they say they're not getting that. what is the ability and how do they report that, file that? How do you look into claims like that?
Well, we know that not to be true. Again, we have surveys. Again, DC Health comes in, a dietitian reviews the diets for the respective patients to make sure they're in keeping with the standard of care required. We have a director of the department who's very sensitive to this issue. We have a good food service. It is not what you've heard in that one-off description by PDS.
Okay. Does the staff eat the meals?
I've eaten the meals from time to time. They're very good. Yeah. They're better than my college food.
Okay. I would like for us to, I mean, I don't think PDS makes things up. So I would like to follow up and make sure we are getting a little more detail about that. And then it seems like it would be good to have a avenue by which if they are experiencing this or if their clients are experiencing this, they have a way to be able to share that information to be addressed. So I know my time is up on this round, but I just wanted to make sure that we flag that. Thank you.
Thank you.
Thank you. Thank you, Councilmember Allen. Is anybody else on this? Okay. We'll wait for other colleagues. I do want to, before Councilmember Allen departs, I do want to follow up on something that you guys were talking about in terms of the incidents. So first, Mr. Chastain, the PRISM reports, the latest one on the website is from November of 2025. When should we anticipate the December report being posted?
45 days after, about soon.
Okay, so
any day. We have a meeting Monday, and I will make sure you get it.
Okay.
And it should be released, weather permitting. There's no major interruptions associated with a forecasted weather storm. Should get it very soon.
Okay.
So the goal is 45 days after the close of the month.
Okay. You also said to Councilmember Allen that each particular incident is followed up upon. In the pre-hearing questions we asked for very specific information on violence. The type of incident, if it was patient to staff or patient to patient, the location where it occurred, the severity level, i.e. verbal threat, physical assault, did it require medical attention, the number of staff affected, and the actions taken in response to each. And in response, we didn't get any of that. So usually then in doing this in sort of performance oversight, it's either agencies give us what they have or the data that is requested does not exist. So why did you all take the approach of not responding?
I think our response was we don't track it that way.
For one of those things, which is the patient on patient, but I would imagine that you track the number of people who were involved in the incident. I would imagine you track the severity level.
Yes. So we track the assault, where it happened and what happened and who was involved, et cetera. Yes, we do that, but you're asking for something specific, and we will create a metric from the ERIS system that responds to your central question, the number of assaults, patient on staff, patient on patients, and what other elements would you like?
I don't think I'm asking for something new. I'm trying to determine what you currently have.
Yes.
If that makes sense.
Yes.
And
Okay.
so,
Copy of it. I have a copy of PRISM. I will share with you. Let's see,
Okay.
where's my-
is this in a database system that executive staff can look at?
Yep.
So this is you running a report.
Yes,
This shouldn't be somebody creating something new, in theory.
that's correct.
Okay. I would just say, I mean, and this is for I'm not picking on you, but I have learned that when we ask agencies for a specific data related question and then they don't provide that data, either you didn't want us to see it or you didn't have it. Thank you.
No, it wasn't us this time.
Okay. Let me go back to staffing really quickly. So the FY26 staffing table shows several clinical categories that have 0 staff in it. So for instance, respiratory therapy, there's a 0.
The contract. That's contract staff.
Contract staff, okay. PT, is that contract as well?
Yes.
OT, that's contracted?
Yes.
And I'm gonna say speech language pathology, SLP, I'm assuming that's what that is?
That's contract.
Contracted, okay. And LPNs, which I know is not a lot. That's rare sort of in the system altogether. You don't have any LPNs on staff.
No, we don't.
Okay. All right, this goes back to the other part. Well, let me ask, nope, let me back up. When you contract, that's for contract in-house? For folks to come in-house and provide services? This is not
Yes.
external? Okay. So in a follow-up from what was part of the testimony from Ms. Samanova around what's she call it? The treatment mall and the reduction from having 2 to 1. I recognize that some of that might have been sort of during COVID, but the patient census has now gone up. So do you have enough current providers to meet the need?
We are looking at reopening the transitional TLC.
Okay.
They're actually supposed to be starting what they call a clubhouse model on it tomorrow. They've been working on that. Opening.
Sorry, what's a clubhouse model?
You're asking the wrong person for that one.
Okay.
She could answer.
Clubhouse model is a model in which the patients have job responsibilities and learn skills that they can then use as they go out into the world and as a part of their rehabilitation. It is a rehabilitation model.
Okay.
So they are starting that up again tomorrow with, I believe, 5 patients off 2 of the units. We are looking at actually trying to open up all of the transitional TLCs, but whenever we do have individuals in care coming in who are COVID, we've had to convert that area back to housing them there to maintain, keep the infection down so it
We have
doesn't
to
spread.
separate.
Yep. Okay. A lot of the vacancies from which you sent over seem to be concentrated in whether it be nursing, behavioral tech, we talked about that, we talked about psychologists. Housekeeping and security is like another area where there's lots of vacancies there. What operational risks are associated with these critical roles? I think sometimes people downplay housekeeping, but housekeeping is important in a hospital in particular.
Yes, it's very important. And it is, the vacancies, I think we have 6, 7.
7 out of what? What's the N? 7 out of 47. Okay.
That's a big number. And we are moving to fill those. How many are posted?
Oh, you got to come to the table. Come.
This is Singh
Come on.
Malaysia, our Chief Operating Officer.
Good afternoon, Singh.
Turn your mic.
Turn your mic on.
Oh, I think too many of you have mics on at the same time. So somebody, okay, there we go. There you go.
Okay, good. Thank you. Good afternoon. I'm Singh Taneja, Chief Operating Officer. For housekeeping, we have 47 positions, 7 of which are vacant, and 3 are in the final stages of recruitment where offers have been made, and they have to just go through the background check and all that.
Okay. So of the 47 that technically would be there, how many of housekeeping is on at any given shift?
So depending on the shift and the time, daytime has more, evening has less, night has fewer than that.
Okay.
And equally important, Madam Chair, excuse me for interrupting, we are recruiting for a new director.
So,
The position's been vacant for about a year.
The director of housekeeping position is vacant.
That's correct.
Okay.
That's very important.
Okay. So several units show census levels that meet or exceed staff capacity. Who's responsible for adjusting staffing or unit operations in real time when census increases, but the staffing does not?
Ms. Ponce?
We staff according to the number of nursing care hours per unit, how many they were supposed to have on the basis of the patients that are there. For every decrease in 6 patients, we will decrease 1 staff. If we have an individual who is on a 1-to-1, or we need to do additional observations, we can increase the staff, but it's done on a day-by-day basis.
Okay. What's the category of patients on unit 1C?
1C is a male pretrial forensic unit.
Okay. What about 1D?
1D is a pretrial female forensic unit. 1D actually only houses 21 patients.
You say only 21. 21 to me sounds like a lot, but
Well, But if you look at the other units, they're 27.
Okay. And what is 2TR?
2TR is a 7-bed unit. We use that primarily for individuals who cannot tolerate the activities that are going on other units. They can't take that internal stimuli. We
Okay.
also have had some patients that have been housed up there because of their level of sickness, but also their level of violence that they have.
All right. So in the data that you guys shared with us, and I'm asking about these units in particular, because they show recurring RN and behavioral health tech gaps alongside high acuity patients. So pretrial, I'm going to assume is high. What additional safeguards are in place on these units to protect both patients and staff?
1C actually has a pilot program going on now when we're talking about the trauma-informed care and having Joan Galise and Raul come in. They're working with them. As far as 1D is concerned, they have been without a nurse manager. We have a person in the pipeline to come in now as a nurse manager for that particular unit. So it's a lot of cross coverage from other people. And as far as 2TR is concerned, there's 1 nurse manager who's been there, but each of the individuals on that particular unit have their own treatment team.
Okay.
Because they are still linked to the home unit where they initially came from.
When a unit, I'm sorry, Councilmember Allen, just give me just a second. When a unit does not have a nurse manager, who's the interim?
Generally, their sister unit is the manager.
So someone who might be across the hall.
Yes, can be across the hall, can be next door.
Okay. All right. Councilmember Allen?
Thank you very much. I wanted to follow up, and maybe it's just for clarification purposes, but the chair asked a couple of questions around the treatment malls, and I was going to ask some of those questions, and I think she covered most of it, but I want to make sure I understood correctly. So the treatment malls have been closed since the pandemic. One of those malls is about to be opened tomorrow or imminently.
The intensive TLC has been open for quite some time. We were able to reopen that when the COVID numbers really decreased. The transitional mall is the one that has been closed since the COVID started. When we've had to cohort patients, we've cohorted them over there. Again, it's set up more as classroom type things, so it really is a temporary move as far as housing any patients there. But we were looking to be able to get open as far as the clubhouse model is concerned, and then ultimately be able to put everything back in there that we had to take down when we had to convert it for patients to live there.
Okay, so the mall was being used essentially for isolation during medical isolation during COVID.
On the transitional side.
Okay, and now it is about to be reopened and put back into use using this clubhouse model.
Yes.
Okay, will there be any other areas that are remaining closed from pandemic era decisions?
No.
Okay, all right, thank you. The last thing I wanted to get into, and it was fairly concerning, was around the quality of care and management of psychiatric illnesses. So we heard testimony from PDS that its clients have had dangerously high lithium levels because staff were failing to monitor levels, which seems like a requirement of anyone who's prescribed lithium. Commission on Mental Health also has had to order medication reviews over concerns about over-medication and inappropriately subscribed medication. And Ms. Butler, one of the public witnesses from earlier who works with the IT system for medications, testified that she's raised concerns to supervisors that patients are being overprescribed and inappropriately given medication. Can you walk through what are the control measures that are in place at St. E's to ensure that patients are having their lithium levels monitored, for example?
Well, we monitor, we have so we have a number of checks and balances on patient medications. Let me ask Dr. Candelas if he will join us, introduce himself to join us in this discussion.
Okay.
We have a director of pharmacy at St. Elizabeth Hospital who's excellent at her role and excellent pharmacy in general. Ms. Butler, to my knowledge, is not referring to St. Elizabeth Hospital clinical activity. Ms. Butler hasn't worked at St. Elizabeth over 6-7 years. We are happy to, and we'll do it urgently, refer to any data or any incidents that she'd like to report. We will follow up immediately after this hearing. Dr. Candelas, if you will introduce yourself and respond.
Thanks for suggesting. Madam Chair, I'm Phil Candelas. I'm the medical director of the hospital. Better? All right. The psychiatrists are responsible for monitoring lithium levels and drug levels in general. The pharmacy backs them up. That's not an issue. What happens when patients are being loaded with lithium, for example, so they'll start off a little bit faster than a maintenance dose, and then they'll be held at something that the doses may, the lithium levels, the blood levels may be above normal. There are ranges of normal for lithium, as there are for many medicines. So I would be very interested to know exactly which patient or which serum level people are worried about. So it's the psychiatrist who follows this, who monitors this. There's a chief of psychiatry as well. And I also get involved as a medical director if there's an issue with lithium. But there are blood levels that have entire ranges of normal. And in fact, there are practice guidelines that urge us to go above certain levels of normal practice in a refractory population. So this group of patients that we deal with, the severely and persistently mentally ill, are often treated somewhat differently than general psychiatric patients because they've been refractory to treatment. They haven't been responsive to treatment. So high levels may simply be part of starting a dose, part of being over a dose for therapeutic reasons, and otherwise being part of a range of treatment.
Okay. But the lithium levels are monitored. You're kind of giving reasons why they may be reporting high, but the levels themselves are being monitored on a regular basis?
Yes, there's a standard of care for doing that when someone is started on lithium and then when they're maintained every few weeks. Yeah.
All right. Again, based on some of the testimony we heard, what happens? What is your process when someone, whether they're a nurse or a psychiatrist, reports that they believe a patient has been over-medicated?
So this is the hospital takes a multidisciplinary team approach to this, and everyone has input. So behavioral input, whether how someone looks, whether they look sedated, whether they're sleepy or they're responding to medicine too strongly, that all goes to the docs. So there's a chain of command, a clinical chain of command, from the team to the prescriber to their oversight. Am I being clear?
Yes, I guess, would you as medical director then in that clinical chain of command, though, are you overseeing all the docs?
Yes, all the docs. So a rare case will come to me if the chief of psychiatry thinks that there's something egregious going on or it's not meeting a standard of care. So let's say a practice guideline changes. So we say benzodiazepines are not to be used more than X number of weeks. Then I'll be involved to watch the data and talk to the psychiatrist as a group. We have monthly peer review meetings. So my role is oversight of data and rare cases.
Okay. And if trying to think through that clinical chain of command, so if a report from a nurse or someone else goes to the prescribing doctor, do you have visibility into that? If there's a report of over medication or inappropriately prescribed medication,
Sure,
the
that can be
doctor,
charted. Yeah.
regardless of whether the doctor brings it to you or not, do you have visibility into that? Is that reported out?
Reported it. It's visible to me in the chart.
Okay.
But I don't get it unless there's an issue.
I guess what I'm trying to understand from the chain of command is it sounds like what you're saying is only if the doctor agrees there's an over medication or inappropriate prescription that comes up to you.
No, I don't want to give that impression.
Okay.
No.
Could you clarify then for me?
So all the disciplines can come to me in medical affairs. So that's not an issue. The nurses can express their concern to me directly if they're not happy with how the psychiatrist or the chief of psychiatry is not addressing their issue. So,
okay. Is it conceivable that a nurse feels like that's a pretty difficult thing to go around their clinical chain of command to go around to you? Is there a way that they're able to reach out in a way that protects themselves, for example?
Look, people drop into my office all the time from the units, from every discipline. So not an issue.
Okay. But you could understand how perhaps a nurse would feel it's a bit of a professional jeopardy to go around their clinical chain of command to go straight to you?
Again, it's a clinical multidisciplinary approach to patient care. This has been public sector as long as I've been part of it. And people aren't shy. So that's not been my experience.
Okay. Last question I have, because I'm gonna run out of time here. Can you walk through what are the steps that St. E's takes when the Commission on Mental Health orders a medication review for patients? If they've been concerned around over medication or inappropriately prescribed medications, when the Commission on Mental Health makes an order, what steps does that trigger for St. E's?
May I take that one?
That's cool.
So this is a reason that we have an independent psychopharmacology consult service led by the chief of psychiatry, which includes the chief residents and other attendings. It's a reason that we try to educate the commission on how to treat refractory patients who don't respond to treatment otherwise. So they generally offer us recommendations rather than orders, so we're grateful for that. Because they don't have the full perspective, the 24/7 perspective on our patients, nor do they have the level of expertise that the public sector has at St. Elizabeth's. So the recommendations are made. We either do a curbside through the chief of psychiatry. A curbside is an informal consultation, or we do a formal consult where the whole team gets together, does the record review, and then reports back to the commission. Just happened yesterday, in fact.
Okay. And that was from a recommendation, not an order?
Yes.
Okay. And just briefly here as I go over time, is there a distinction between what the response is when it's an order versus when it's a recommendation?
I think so. I mean, the issue for us is whether our expertise will be acknowledged at some level. Because if it's an order, then we just do what we're told. But if it's a recommendation, there's a lot more education. There's a lot more input and testimony.
Got it. Okay, that's helpful. I know over time. So thank you, Madam Chair. Thank you, everybody.
Thank you. I want to continue on in terms of staffing questions. So the FY26 year-to-date turnover rates is already higher than prior years for both RNs and behavioral health techs. Mr. Chastain, when we spoke in December, you said last year you all hired 16 behavioral health techs, but 11 left. In total, hired 67 folks at the hospital, but 70 individuals left. So got more people leaving than we're bringing in for a variety of different reasons. What reasons are staff citing when they're resigning?
A number retire.
Got to use your mic.
I'm sorry. A number retire. That's a frequently offered reason. Others take jobs in the area. These are hard to recruit, hard to fill individuals who are highly sought after in the market. So there's a competitive process. During COVID years, we didn't have, we had a lot of staff leave because they didn't want the exposure that we were having.
And I hear you.
Violent.
I don't want to diminish what happened during COVID. However, we keep using COVID as the crutch and it's 2026. So like 2025 was not a COVID year. There were COVID cases, but it was certainly not a public health emergency. So I'm trying to understand, I know there are lingering reverberations, but every response can't be but COVID when it comes to staffing.
Yeah. So when I say that, I'm reflecting the reality at St. Elizabeth Hospital, the impact COVID had on the staff emotionally, programmatically, redesign of the hospital, the flare-ups we had. In December, I think we had 17 cases. This past December, 17 cases, flare up, reminding everyone of the extraordinary trauma. 17 patients died, a number of employees, and all that came from that unprecedented experience worldwide.
I'm totally,
And so,
COVID's here. It's going to be with us.
yeah,
Like flu and
for
RSV
those-
and all of these other things. And so I think we got to figure out how do we deal with some of the staffing challenges as opposed to just saying the trauma of COVID.
with dignity and carefully and in accordance to guidance from experts. That's how we deal with it. And so we don't take it for granted. We don't treat it lightly. We follow CDC guidance. That's essentially what I'm saying.
Okay.
We don't.
You guys don't
And
do
so,
exit surveys. You say that they are voluntary and infrequent. Why can't DBH require completion of an exit survey as part of the exit process?
we can, but we haven't. I mean, we've had so many other priorities and issues. We've not formalized an exit survey. I actually remember approximately 9 years ago, we were doing it more frequently. It just hasn't been a priority, if you will. It is voluntary. And if persons offer that information, we will include it.
Okay. I've got agencies who've got lots more people who an exit interview, an exit survey is part of your offboarding. Doesn't have to be long.
Yeah.
Just give me some feedback.
Yeah.
What happened? What can we work on? And I think that's a thing that might be healthy in an environment where you have a lot of people who are leaving. Don't you want to know why? And how we could sort of improve on some of those things. And I think that brings into the question of overtime and fatigue. Okay, DBH states that mandatory overtime is only used in emergencies. How do we define an emergency?
I'll start with a general comment. Anything that has the potential to be a harm to the patient or staff or students or whomever else may be involved.
How often is that standard evoked?
Whenever there is a threat of harm to any person involved. Marty, would you like to?
I mean, under that could be daily.
Yes, and it is daily.
Okay, so mandatory overtime is a thing.
No, so for example,
Okay.
in the next 48 hours, it may be a thing.
Yes, because of a weather event, but
Yeah.
let's say somebody on a unit's mom got sick, they had to call out. You're down one.
Yeah.
Do you use mandatory overtime to make sure that the unit is fully staffed, or do you just let it ride with 7?
Our first action is to ask for volunteers. And we will get volunteers
Okay.
who will stay because they're committed to what we do. They know the circumstance we're in.
Are there caps on how many hours someone can legally work continuously at the hospital? So for instance, Office of Unified Communications, which is down the street from you, 911.
Yes,
There's only but so many hours before they say, no, you have to go home because health-wise,
yes,
you're gonna make a mistake.
yes.
Do we have that for the hospital?
We have
Sixteen,
reason.
yeah.
Go ahead.
It's 16 hours.
16 hours.
16 hours, and then they must, we do have some folks that will push the limit and they'll try to go for 20, but that's always a big discussion. But there's also, according to the contract, they should have an 8-hour break before they go back on duty again.
Okay, so 16-hour max, 8-hour break before going on again. Is that standard? Like if I inquire to the DC Hospital Association around what is the standard in terms of the max level that a nurse could stay on, is 16 high?
That's what our standard has been since I've been at the hospital.
How long have you been at the hospital?
16 years.
Okay. But still, I'm asking in sort of the scope, is 16 high? Do we know? Have we done a sort of survey of the landscape and environment?
Not of the external environment. However, we do monitor the number of hours that an individual is working overtime. When they hit in the 2-week period of time, when they hit 40 hours, they are then supposed to make sure that they have requested to be able to work and it's been signed off by a supervisor. So somebody is aware of what they're actually doing.
Okay, let me ask, is someone allowed to work overtime if they miss their regularly scheduled tour of duty?
They are, but they're allowed to work, but it's not paid as overtime.
So it's just your regular? Okay, I'm asking. We're having a large conversation across the government about overtime. And I'm of the opinion that you don't get to show up for overtime if you didn't show up for your regular. Because
Correct. Correct. But they do fight us on it.
sure, but like even when we're kids, right? We have this conversation in terms of I have 2 kids who are in elementary school. And there's a whole fight about whether or not a student can participate in extracurricular activities if they did not come to school that day.
Right.
No. So why would we allow for someone to work overtime if you couldn't make it to your regular shift? That's costing me more money. Also, it sets up a terrible incentive because I would just always work overtime and never come for my full time.
That's why we don't pay them overtime when they show up.
Okay. Remind me of your name again.
And Ms. Pontus.
No, the COO.
Singh Taneja.
Mr. Taneja. Okay, so I was gonna say Mr. Singh, but that's your first name, not your Taneja. All right. How much overtime did you guys use last fiscal year?
Altogether, about $10 million.
Okay. Oh, the AFO is here. I'm gonna ask you, but I know that he has the numbers because he holds the books. How much overtime was budgeted for last year?
$1.9 million.
Okay, how many overtime hours altogether?
I don't have the report with me.
Okay. Adrian, do you know that part? Come on to the table. Ms. Ponce, if you could switch out with the AFO. We're not picking on you. I'm telling you, everybody's going through this exercise on overtime because how we budget for overtime and then what we spend just never matches up. If you could introduce yourself for the record.
Hi, I'm Adrian Reed, AFO of DBH. I completed an analysis a few months ago, and based off my memory, I believe for behavioral health technicians, there were 92,000 hours of overtime. And I think the other major category were in the nursing unit, and there were about 60,000 hours of overtime. Each costing around $4.5 million estimated. So I think those 2 units were the majority or the bulk of overtime.
Was from behavioral
Health technicians
and
and
nursing.
the nursing unit.
Okay. All right. But the overtime is considered an emergency.
Well, it's.
Oh, yep, sorry.
It's necessary in every hospital across America, especially so during COVID emergency.
Yep.
Hate to keep referring to that, but you know, it is urgent to have adequate staffing, safe staffing to make sure the patients have the appropriate care and treatment. Overtime is necessary.
Yep.
It's never at zero in any hospital in the country.
Here's the thing that I'm trying to struggle with. So I know that last year budget was because Congress decided to involve themselves in matters which they did not know about. So there were positions that were frozen, but I also know that there was a process for which agencies could petition to the city administrator of, I need these positions for life, safety, critical thing. I feel like the psychiatric hospital falls into that category of life, safety, and critical. Why did you guys not ask for your positions to be released when you're 92,000 hours of overtime for behavioral health? When you had 16 positions available to you, but they were frozen?
They were not.
Can I address that? From the OCFO standpoint, we're at the end of the process, and I know that you know that.
Yeah.
But I can say that I've seen the request that Dr. Basron sent to request for positions to be released. So I'm not, I don't think the positions were not released. There's another issue, and I'm not sure what it is, but it's not that the positions were not released or requested to be released.
Okay, Dr. Basron, I know you probably made the request. Were your requests heard?
Yes, positions at the hospital were considered health and safety positions.
Okay.
And they were not a part of a freeze.
Okay, so in December, when you guys told me that some of the vacancies, these were frozen, what was that?
Positions were not frozen as a result of the budget impact.
All right. Okay. Then I stand corrected because I was under the impression from a conversation with you two that you had positions that were frozen under a freeze last year. All right. Okay. I'm yeah, okay. Sorry, I was checking with my staff who was also in that meeting. We both heard frozen. So now we're gonna have to trust but verify going forward. We see. Retention bonuses, is that a thing that you guys use from staffing?
Yes, Marty? Yes. Phyllis, yes.
Okay, how much?
Answer is yes.
Okay, how much do you have budgeted under that sort of line item?
Sufficient to meet the CBA requirement. I'll look for it here just.
Okay, how much is the bonus?
Is it
It's
$1,500? Go ahead, Marty.
$1,500. The bonus, for example, in
Okay.
FY 25, 171 nurses received a $1,500 retention bonus, which added up to $256,500. And that's a part of the DCNA collective bargaining agreement.
Okay. So the 1,500 amount was bargained for.
That's right. That's
Okay.
a part of the bargaining agreement.
I'm just checking and make sure no colleagues will keep going. Ashley. Okay. All right. Okay. One of the other things that has certainly come up here as an issue is around inventory and supplies. Adrian, before we switch out and question, I want to ask you this. In terms of the supply line for the hospital, did it use all of the budgeted amount of money that was budgeted for under supplies?
At this time, I don't know the exact number, but I can get it to you within this hearing.
Okay.
I just have to check. some
Okay, why don't you do that? And let me ask some questions about this. Okay. We talked about supplies, and I think there's some disconnect, but also some follow-up. So the last hearing in May, the big supply thing that we talked about was the glucose monitors, right? How that was the thing. Great. Then I heard, okay, yep, you got the new monitors, but the monitors don't work with our current systems. So why do we buy them?
The monitors don't download until we make an IT adjustment. Don't download automatically the data from the device into our electronic health record. We have a plan to do that. Singh, do you have the status of that?
Sure.
Your mic.
You gotta turn your mic on, sorry.
I apologize.
No, it's okay.
There's an interface that connects the glucometers with our IT system.
Yep.
That interface is being acquired. Purchase order has been issued, or I should say OCP is issuing the purchase order. And we anticipate that it should happen within this year.
Okay. Did you all know when you purchased the monitors that it was not going to speak to your system?
Without the interface?
Yeah.
If we knew that it would.
Oh, nope. You got to turn on your mic. I'm sorry.
Yeah.
Just leave yours on.
Yeah.
Okay.
We knew at the time that there would be this IT adjustment required to achieve interface. Well, that was not enough of a reason to delay going ahead and purchasing the new glucometers.
Oh, but then you purchased something you can't use.
We are using it. It does give us important information to keep patients safe, to know their glucose levels, so diabetics are treated appropriately depending on whether it's high or low. Their glucose levels are high or low.
Yes, but it's just from like a pure process standpoint. If I am searching, I don't know, for something for my home, and it's like, it's going to require 18 batteries in order for this to work.
Yeah.
I usually am like, all right, either I'm going to purchase the batteries at the time that I purchase the thing. I certainly wouldn't say I'm going to buy the thing and then buy the batteries a year later. Because that's what this feels like. If the whole point of the glucose monitor, at least from the hearing in May, right? Lots of nurses talked about how this is slowing down the process in terms of them checking with patients, particularly those who have diabetes. Okay, cool. The solution, new monitors, great. But if the new monitor still requires me to check it by hand, write it down, go to the computer, put it into the system, you ain't telling me no problem.
Yeah.
So that's what I'm just trying to understand who. OCP was the one who did the purchase order for the glucose monitor?
Yes, they do all purchase.
Okay. Did you all recommend a brand? Or did OCP do the research and analysis themselves?
No.
Sometimes they do.
Marty?
Come on to the table. Yep, just hit the button. It's not on.
Turn this off.
There you go.
Okay. We had a contract with Abbott.
Okay, lower your mic. There you go.
We had a contract with Abbott as far as our old glucometers. That
Okay.
contract was through our information systems, through IT. IT was the one that did all of the communication with Abbott to get the new glucometers in. They also knew at that time that they were going to have to do some more interfacing as far as the computers were concerned. During the time that we were waiting for the glucometers to come in, and even after they did come in, IT has still been doing significant rewiring throughout the hospital. That's now done. So now we can go forward with the purchase order to start working with the Orchard system, which is part of the lab system, to get the two to communicate.
Okay, how long is it going to take for them to bring on the new system?
If I knew, the
Oh, I'm
last.
asked the COO.
Yeah, we don't know.
I don't know the exact date, but I think within a few months, within this fiscal year.
Yeah.
Within this fiscal year.
Okay. Okay. I'm gonna feel like I've beat that one down, so I'm gonna leave it. All right, so let's move to the other question around supplies, just as sort of in general. Now, this has been a floating question. I've asked it multiple times. Is there an inventory system at the hospital?
The hospital does not have an automated inventory system. It is looking at one, and we plan to acquire one and install one in this fiscal year. But at present, our system is a manual system, meaning we have individuals who provide supplies to the units. And they look at it. We have another individual who physically walks to the units. He will ask every unit for their needs and then give them the supplies. Also, earlier we discussed the group email TMS system.
Yep.
That system is also used to send emails to the individuals. Yes, it does go to multiple individuals so that they can pick whichever individual has to address that need.
Okay.
It is not the ideal system. I'm the first one to say
You
that.
guys talk to Octo? I know you're quasi-independent. We got a whole agency who could make y'all a quick base app real quick here so that you're not relying off an email system.
So yes, we have. And actually, our facilities team, Mr. James Dover, he worked with Octo through our IT for about a year.
Okay.
And at the end of it, the contractor who was helping them, they could not deliver. And it was actually on a work order and inventory system. So once we had that clarity, then we started looking for other alternates. And this was developed in-house because we wanted to make sure that there was at least a backup system, not the ideal, where individuals can submit their request and we can start delivering those requests.
Okay. How long is it gonna, well, you said you are thinking about starting the process to gain an inventory system. So there is no RFP, RFA that has been written.
We know the operating requirements of a hospital inventory system.
Yep.
But it has not been submitted yet, but we anticipate that it will happen this year.
And I know this isn't something was necessarily budgeted for because we would have talked about this last year. So how are you all going to pay for it?
So we will utilize our capital funding to do that.
Capital funding.
Project funding, DBH capital projects funding, yeah.
Okay, so let's talk about what we got now, because this RFP process could take some time. This is what we got. Is this what you guys see? When the executive, sorry, I know you're like, what is that? Okay, this is the work order document.
Yeah.
Ish. We had to ask for it in a different format because we could not read it the first time you guys sent it, but this is the workforce document. Is this what you see?
Yeah.
Work orders come under you?
They do, they go under one of my staff, yes.
Okay. It doesn't tell you what date the work order was submitted. So how do you all track how long it's taking completion?
So they track them, and when that data can be produced, they do track them when it was submitted, because there's an email that comes, there's a date on the email. And as they respond to that, they track that information.
So did you guys did you send the committee a different report?
No, but
I don't ever like for people to make up work,
Sure.
right? So when I'm asking for a report, it's usually I'm asking for what you already got, whether it be for the school system, whether it be for DC Health, any other agency, boards. What do you have, right? I don't want to make work. I'm not trying to make bureaucracy. So I'm assuming when we asked for, tell us about your work orders, you would send me the report that you have. So I'm assuming this is what you get. And there is no way to say how long a work order has been open because you don't have when you got it.
So I will go back and I will look at the information, and I'll make sure that the next report we give you has what you're asking, the dates and all that.
Okay.
We'll make-
Unfortunately or fortunately for you, there is a performance oversight hearing for the Department of Behavioral Health in a few weeks. We're going to talk about this because some of these things on here, all right, a light is out. It's not critical, crucial, but it'll be nice for it to get resolved at some point. There's some other things on here about medication room locks not working. Problem. And I'm trying to understand, the reason I'm asking this is how do things get prioritized and elevated in your system so that we know, okay, these are the critical things. I just had a hearing last week with DPR and DGS. We know from their system, hey, a part needs to be ordered. Hey, we've looked at this and it's going to be a larger capital project, so we can't address it right now, those kinds of things. But it allows for folks to know, number one, for the person who submitted the request, that your request has been reviewed and just didn't go into a black hole somewhere, which unfortunately, there are people who have been emailing 4 and 5 times about the same issue. So that means that they feel like they haven't been heard. And to the point around staff morale and staff retention, this is small, but it goes into people feeling like the executive administration actually doesn't care about the workplace environment. That's why I'm harping on work orders, because it's small, right? Can the bathroom get fixed in the staff lounge? That takes 6 months, then that means that you don't really care that I couldn't go.
Well, we do care, and the facilities team does walk through. They walk through every unit, they look at each of these, and they do talk to the staff over there. Sometimes a part has to be ordered, sometimes either a contract has to be let out. These things are discussed with them. They do walk through it.
Okay, so let me ask you this as the COO, what's the oldest work order that you have open in your system?
I would not know now, but I'll be glad to provide it to you.
Okay, this is a, this is what I'm trying to determine in terms of level of priority. Your hospital, so fine. Patient care, super important. The work order piece though, that's part of patient care if some of these areas aren't. And when we harp on work orders, if I were to call the head of DGS and say, what's your longest pending work order for DCPS? He would be able to tell me how long it's been and who he's talking to and how they're following up on it. And I don't see that level of interest.
No, there is interest, and I must say that we used to have a system called TMS.
Okay.
We're using the same terminology here. That system gave us that capability. That vendor, that system, there was some issues related to the contract. That vendor is not with us anymore. So we are looking at another system. So we're looking at 2 different systems. One is a work order system, which is internet-based, and the second is inventory management. Those are 2 different systems. We are looking for those 2.
Okay. How long has the TMS contract not been working or available?
I would say about 2 years.
2 years. So we've got
A little less than 2 years.
2 years without an inventory management system for our only public psychiatric hospital.
Not inventory management, but the work order. Those are, again, these are 2 different systems. One is a work order management, which reports a toilet is broken.
Oh,
or
my
lock is
apologies.
broken.
How long have we not have an inventory management system?
We never had one.
All right. So 2 years, never had it. All bad. Let's fix it. Let's work on it.
You have my commitment. We are working on both of those here.
Okay. Before this escapes me, I just want to ask, this might be more of a medical director question than maybe a COO question. Because I want to make sure that I'm following up on the testimony and the other things that we sort of heard. But while we're talking about contracts lapsing, I would love to know what happened with the ophthalmologist provider or optometry. Not what happened. Fine, the contract ended in September, but I'm curious why we don't have a provider who was ready to go to start the fiscal year.
So if I may.
Sure.
Dr. Bisholte, who was the ophthalmologist, she decided after many years to not have the contract for personal reasons.
Okay.
And we are looking for another provider. In the meantime, we are sending our patients outside for those services.
Now, sir.
And you asked the question before, how many cancellations have been there?
Yeah.
We have the information, and maybe Jillian can report it. We had it.
Okay. Oh, if you want to hand it,
Yes, yeah.
somebody
You
with,
can-
you have to
yes.
say it on the mic.
So during the fiscal year, during the calendar year 2025.
Okay.
So January 1 through December 31, during those 12 months, due to transportation, there were 23 appointments canceled, about on an average 2 a month. We also had data for other reasons, and that was only for a short window, like for this month. This month, we have had 10 by discharge, meaning the patient was discharged. So by the time the appointment time came, the patient was discharged. 5 were canceled because they were canceled by the provider outside, the external provider.
Okay.
Where the appointment was. 5 were canceled by the SCH provider, our provider here, the person who wrote the order, they canceled for whatever reason. And then 1 was canceled because of because of the transportation or the late. So those were the reasons they were canceled this month. So only 1 for that reason.
Okay.
And
But so in sort of the breakdown, because this is something I noticed. So you gave me for calendar year, 23 cancellations for transportation. How many cancellations all overall for?
I did not have, we
Okay.
just asked for a quick count.
The in is important.
No.
But I'm gonna assume for this year, what you just gave is that there have been 21 cancellations.
Right, and I gave you the reasons also. Only 1 was really for the reason of patient being late, or all the other were not related to what happened on the other side. Also, you had asked about earlier, you know, is there a discussion about this data and how do we gather it? And interestingly, I just looked at my notes. On January 6th, so which was 2 weeks ago, Dr. Wilson, who is in charge of these areas, myself personally, met with Ms. Quanders, who previously gave the testimony on January 6th, and we asked for that data, that we would like to see that data. We're still waiting for that data. So we do follow up on these things to get the information. I have my notes over here that we do. I'm interested to know how many appointments were being canceled. Also, every day before the day ends, transportation sends an email to about 50 individuals in the hospital, giving them a schedule of tomorrow's appointments. So it shows the name of the patient, where they are going, what time is the appointment. So that information is shared every day for the next day.
This is helpful information. The thing is that you said that when you met with the medical clinic staff, you asked for the data. And I think Dr. Wilson is a medical director, yes? He's not here, but I believe he is a medical director, or that's how you've sort of
He's a
presented
general
him.
medical officer. He's the chief
General medical officer. I'm trying to understand why you had to ask the clinic for the information, but it wasn't something that you already had available.
So I asked Ms. Quanders for the data, Dr. Wilson and myself, because
I know
that is
you
the
wouldn't
staff.
necessarily have it as a COO, but he would, no?
But that's the data, that is the staff that has the information because they're the ones who make appointments. They're the ones who are notified about the cancellation or they receive the information. We just want to know so that if there's an issue
Yeah.
on the hospital side, we want to address that.
Sure. Ms. Ponce, if there was a patient and you wanted to look them up to see if they had any appointments scheduled that day, there's a system you can do that, yes?
Yes.
Okay, so, all right. I'm gonna, wait, no, I'm not. I'm gonna go back because you got me off track. I was asking about the ophthalmologist contract. I have to imagine that the current provider, at least I know about contracting procedures, because I did a little bit of this for DCPS back in the day. But if there is a base contract with option years, before you get to September 30, somebody is asking you, do you have an intent, like, me, the agency, I would like to continue with you. You, provider of goods, do you want to continue with me? There's a conversation before September so that we know whether or not we're moving on together. When did you all know that the provider was deciding that they did not want to continue?
They notified us before the end of the fiscal year.
Okay.
Because of, again, changing their personal situation, nothing to do with what we do at the hospital. And we started looking, it's a very small contract. It's difficult to find providers who will want to come to the hospital few hours a week or a month and, you know, change their practice pattern. So it has not been easy to find a provider, but we are in the meantime sending patients outside so that they are receiving services.
Okay. And when is the request for applications for that position going to go out?
It's not a position.
Or I'm
It's a
sorry, for that
contract.
contract?
So we have been working with OCP for last couple of months.
Okay.
More than
So
that.
I wonder, are we paying more money to send someone to a private provider, right? Because when I put into, okay, not only do I now need an escort to go, I need a transportation person to go. They're gone for X number of time, as opposed to the escort going 2 floors up, 3 floors down, wherever that office kind of is. It just allows for it to sort of be contained. Are the transportation, is that a private, the transportation component of someone going out, is that a private contract or are they staff of the hospital?
Staff of the hospital.
Okay, how many people do we have doing that role?
We have 2 individuals right now. There are others who are helping out. We
Okay.
have 1 vacancy in there, which we're, trying to fill. But we do have others, individuals who help out.
Okay. I want to switch to staffing, talking about security operations. So when we talked in May, this was a question that came up around the number of security officers that are available at the facility during any given shift. Now, at the time, I believe you guys had at least 5 to 6 SPOs per shift. Is that still accurate?
Yes.
Yes?
Yes.
Okay. How many units do we have that are operational?
12.
Got it, you might. 12. Okay. Is 5 now, okay, let me back up. The SPOs that are on the shift, is that for both internal and external? i.e. they
Inside the building.
inside and outside of the building?
The grounds, yes.
And the grounds. Okay. Is the SPO, is there a SPO on station at the front desk? So I guess when somebody comes into the hospital?
So there are SPOs and SOs. There's security officers and special police officers.
Okay.
And so you're asking about the SPO group now,
Mhm.
right? Okay.
Well, what's the distinguishing function amongst the two?
One has arrest authority. That's a major distinction.
SPO.
Yes.
Okay.
The SO does not.
Okay.
One would be involved in restraints, the other would not. The SO would not. The SO would man the check-in stations. When you came to the hospital,
Mm-hmm.
you came past a checkpoint.
Yep.
That's an SO.
On the outside,
In that booth.
in the booth.
You
Yep.
came by is an SO.
Okay.
When you came through the lobby and went through the magnetometer, that's an SO.
Okay.
When you go out onto the patient units, frequently you will interact and see special police officers, SPO.
Got it. Okay. So SPOs are generally internal in the unit type work. SOs are generally on the campus level.
Perimeter, yeah.
Okay. When we say, give me a minute, Councilmember Parker. Let me just finish this line of questioning really quickly. So when we say 5 to 6 per shift, is that combined, or is that you have 5 to 6 SPOs and then there's a certain number of SOs?
It's usually 4 or 5 SPOs and 2 or 3 SOs.
Okay, so combined. So, all right. Is that adequate number to cover the units plus the external, given the population that you currently have at the hospital?
In the past, it has been more adequate than it is now. And an evaluation is underway as we speak of adjusting, that is increasing because of the changing patient mix. 95% of our admissions now are forensic.
Yep.
They are high acuity patients on average. They're more aggressive. They're younger. And they need more clinical intervention more frequently than had been the case years ago. So we need to adjust our security supplemental staff to meet the changing patient population, and that evaluation's underway as we speak.
Okay, I'm asking my staff to note that. We'll pop back on this in February. There's a lot of things that are ongoing. Do you all look at the actual response time metrics when a code 13 is called?
Yes.
Why are they not routinely reported?
Well, we do look at it. We do evaluate it. The chief of security, and we make adjustments accordingly. She does retraining, particularly on the highest acuity units.
Yep.
We do audits periodically. The assault committee discusses this issue.
Okay, so we asked, and this is why I'm going back. I don't like to make you do new work. I asked in the pre-hearing responses, what's the average response time for security calls? And all you all said was security responds immediately.
Well,
clearly, if you have the information, because you audited it, as you said on the record, you can run a report.
well, Madam Chair,
Okay.
security supplements the clinical team that's always on the unit. Okay, so there is a immediate response when there's potential danger to self or others, the patient that may be precipitating this concern, and the staff. Marty, would you like to comment as well, just to give clarity? There's never an occasion where there's not an immediate response to aggressive behavior, because there's always staff on the unit. If the
But if I'm
patient,
being aggressed,
huh?
how am I responding?
If there is a perceived threat, they will call it code 13, which is a call for assistance from SPOs.
Right.
To help make sure that there's no harm to anyone.
Yeah, so our question was, what's the average response time for the SBO to get from wherever they are in the hospital to said unit? And you said in your testimony, you reviewed it. So I'm confused why we didn't get that.
I'm sorry, we said in our testimony what?
You just said to me,
Yeah.
not 5 minutes ago,
Yeah.
that you review the response times, you all audit it periodically.
Yes.
Then my question is, then why could you not respond in the pre-hearing responses when we asked what is the average response time?
If you were asking for a metric that we track, to my knowledge, we are not tracking response times, recording it in a formal way as we do with those 24 metrics I just gave you.
Yeah,
That's the context that I was responding to your question.
okay.
Do we track response time by the SPOs to a code 13 in the same manner we do for those 24 metrics? No.
Okay. I feel like this is a risk management piece, labor management stuff. Because if you have a staffer who gets hurt on a unit and there's a lawsuit or case thereafter, they're going to say, I called for code 13. And then somebody is going to do an investigation. We're going to look at the tape and we're going to figure out how long did it take for someone to come help. And if every instance is investigated, then that is something that should be documented. How long did it take for help to arrive? And I recognize, yes, there's staff on the unit, but again, we know that there's some staffing shortages, right? Not every unit is where it needs to be. We talked about that. Ms. Ponce and I talked about that earlier with the like 1C, 1D, 2TR, right? So if there's like 3 of us and Maggie's getting jumped, somebody's calling for the code 13 because Maggie can't do it because, Maggie's doing whatever. And then someone else is having to watch everybody else. So who is helping Maggie in the moment, which is why it's important to know when did additional help arrive.
When a code 13 goes off, there on the daily assignment sheet, it's placed on there. Who is the BHT from another unit who is going to respond to the code 13? If it's a code blue, which is more of a medical emergency, it's listed on there what RN is going to respond. So it's not just the SPOs that come to a code, it's staff from other units. Now, there are a couple of, we don't have an actual formal arrive now, and that sort of thing. What we do have, however, is we can get the time that the code was called because that is logged at the front desk by the person who makes the call. When we look at the actual tapes of what happened, they all have a clock on them. So you can see when the SPOs or when you can see when other staff came in. So you'd be able to extrapolate it out.
Yeah.
But an actual press the button on a computer screen and get everything printed out in a regular report. No, that's not there.
Okay.
But it can be obtained.
All right. I'm going to turn to Councilmember Parker.
Thank you, Chairperson Henderson. And in full disclosure, I've been jumping in and out of today's hearing for other hearings. And so I may ask questions or cover content that may have already been covered. My apologies. I would say at the outset, though, this has been a deeply unnerving hearing. Like arguably one of the most unnerving hearings I've sat through during my time on the council. And I'm not surprised why this isn't front news coverage. And I suspect it's perhaps because of the clientele that relies on St. Elizabeth that this isn't receiving more attention. So thank you, Chairperson Henderson, for this hearing. And I just want to note that I personally plan to follow up because I've just been deeply troubled by today's testimony. Dr. Basron, what steps are being taken to make sure that medications are appropriate for patients? We heard, I thought, moving testimony today. I believe she was a pharmacist, but of overdoses that are going unreported. Pharmacy employees being told to refer or report internally errors that are made or dosages for different medications being messed up from different visits. What steps are you taking? Is the team taking to make sure that medications are appropriate for patients?
Well, as was said earlier, council member, one of the things is that there is a pharmacist that's on site and a pharmacy team on site at St. Elizabeth's Hospital who is responsible for medications. In addition to that, Dr. Candelas, the medical director, is responsible for having oversight and following up to ensure that not only the medication that people receive is appropriate, but
Is that
there's
person
no
here today?
over-medication. Yes, I'm going to turn it to him in just a moment, to Dr. Candelas.
Okay.
Go ahead.
Hi, Phil Candelas, the medical director of the hospital. So the standard of care for psychiatric practice is set by guidelines, by academic practice. We are a teaching and research hospital, so we advance those guidelines and the standard of care. We're also a forensic training program, so we teach
I'm
others.
sorry, just for the sake of time, I get all of that, so I'm just gonna push. So we heard testimony today that when a pharmacist prescribes 50 milligrams of medicine X, that information is being input into what? Or
I'm not
where is that
familiar.
information going? I'm sorry.
I'm not familiar with the pharmacy program.
Okay, how is medicine being distributed there at the hospital?
You want to address the Pyxis? Does someone
Yeah.
address? I'm not an
So,
expert in.
so physicians order medications. Psychiatrists and general medical officers order the medications.
Yeah.
But let me say just at the outset.
Well, but wait, before we go there, I just want to walk through, but to make sure I'm clear, because what we heard today is that, if I remember correctly, a pharmacist is inputting the medication, but however it's being interpreted it on the unit or by someone else, or because these systems are disjointed, there's different cadences that are being honored, or there are so many errors. Even more troubling, we heard that when these overdoses and other errors were brought to one's attention, the pharmacist was told to report that internally, as if to say, we're not going to make that publicly known. And so I'm trying to better understand the internal process.
Yes, council member, I can tell you with 100% confidence that that statement doesn't relate to the operation of the pharmacy, how medications are prescribed and taken by patients at St. Elizabeth Hospital. The person who made that comment earlier does not work at the hospital, has not worked at the hospital for over 6 years, 7 years. We have an outstanding pharmacy surveyed annually multiple times, as is the case across the nation with pharmacy and medications, because it is a very serious business. We take it seriously and monitor it continuously. We have licensed pharmacists at the hospital daily. We have committees that oversee the use of medications. There are very rigorous standards and controls on medications, particularly narcotics and other such medications.
Sorry, I don't want to
and-
speak over you, but it's hard to jump in, and I only have a limited amount of time. How are errors or overdoses or I don't know if I call it misprescriptions or errors in how medicine is prescribed, how is that recorded internally and reported externally?
It's recorded by our pharmacy and nursing team. And there's a committee that reviews all of this information, adverse drug reactions, errors, etc., monthly. And it's a very rigorous, serious process led by and participated in the deliberations of the committee by experts in this area.
And so do you have at the ready stats where we are today on those errors in terms of prescription and where they were last month?
Yes. The Pharmacy and Therapeutics Committee is the committee. And oh, by the way, our pharmacy was surveyed recently by DC Health, and guess how many violations we had? 0.
Well, respectfully, that doesn't mean there are no violations. Respectfully.
No. I can't let that slide, if you will, with all due respect. We have expert, professional professionals who do this and
I
take their
don't
work
discredit
very
that.
seriously.
I don't
And,
discredit that,
I
but it
have
is
great confidence in them.
it is very clear to me based on the testimony that I've heard today, and I know people that work at St. Elizabeth. I don't think all of these people are making it up. And so I do not mean to undermine, demean, or discredit the hard work of the team and the staff at St. Elizabeth, but I do want to get clear on this issue because I think it is hugely alarming. So where are we so far this month, and where were we last month in terms of overdoses and or errored prescriptions?
We have information that I will get for you from our
Okay.
Pharmacy and Therapeutics Committee around adverse drug reactions. What else would you like to see?
What I was alarmed by, if accurate, is the testimony we heard where the pharmacist was encouraged to share reports of overdoses internally. And so it sounded like she was instructed to tell her manager, not some committee, formally, which one can assume that the data we are receiving publicly may not be fully accurate if we take her testimony to be accurate.
You mean the testimony earlier from one of the witnesses earlier?
Yes, yes.
If it's Miss Butler is not a pharmacist. She does not work at St. Elizabeth. She's not referring to what goes on at St. Elizabeth, to my knowledge.
Okay, maybe my recollection is off, but if you could share that
Miss-
data, that would be helpful.
Yeah, the witness that discussed earlier the issues you're referring to is not a pharmacist.
Okay, but the topic, maybe I misheard the title, but the topic is accurate, that there are errors and overdoses that are not accurately being reported publicly.
Not at St. Elizabeth Hospital, but I will follow up in whatever manner you'd like to have
Do you have, I know
information.
you're going to follow up with that data, but do you have a sense of where the numbers are for overdoses and or error prescriptions?
It's too serious of a matter to speculate. I don't have that information at this moment. I will
Okay,
get it.
if I'm gonna stick around for another round, if you could phone a friend to get that information, I would like to know, because what you're saying on the record is that the testimony we heard was inaccurate. At the same time, you don't have data to refute it, and you're suggesting that it's not an issue. We've heard that testimony from a number of people. I would also just say we heard it from PDS as well. This concern about errored prescriptions and or medications being given erroneously. I'm out of time this round. I do have more questions, Chairperson Henderson, but I want to honor the clock.
No, thank you, Councilmember Parker, and you're correct. I just noted that Ms. Samanova did talk about wrong medications in her testimony as well. So that definitely came up. While we're talking about medications, can I ask as a follow-up from the testimony that we heard from Dr. Boyd as well as Ms. Poraccino, what policies cover the use of chemical restraints?
So may I take that one? So chemical restraints are not used in psychiatry. This is a misnomer. It's an outdated way of talking about medicine. Chemical restraint is defined as something which limits someone's mobility exclusively or sedates them. It's not as needed medication or PRN medication, which is related to a treatment plan or a condition. So chemical restraints are not permitted. They're not used. We had an external consultant come in from Hopkins on a particular case where we had a disagreement on this definition with disability rights, and our use of medicine was not defined as a chemical restraint.
Okay, so it feels like we have a difference in terminology, but you do say that you do use drugs for sedation.
No, I did not say that, Madam Chair. What I'm saying is that that's the definition of chemical restraint. Chemical restraint is the use of a medicine in order to limit mobility or to sedate someone. It's not related to treatment. It's not related to someone's condition. What Ms. Poraccino said is that as needed medicines were being used as chemical restraint. That's a misnomer. It's a misrepresentation of a history of public psychiatry that for decades has been against chemical restraints.
Okay, so I'm going to ask my question in a different way. Are there medications that can sedate someone that is used at the hospital?
Yes, medicines can sedate patients, yes.
And then my second follow-up then would be, what are the policies that cover the use of said medications that can be used to sedate?
That they have to be related to treatment or a condition, right? Or else they are chemical restraint.
Okay, so if not related to treatment or a condition, it is then a chemical
That's right,
restraint.
because they're specifically used to limit someone's mobility. That's not permitted.
Okay, who can prescribe, because I'm assuming it's a prescription that would be needed, who has the authority to prescribe the use of a sedation medication?
Physicians have prescribing authority.
Okay. That's, let me ask. Okay. Okay. I want to go back to facility and maintenance. Mr. Chastain, you talked about in your testimony that the building is at about the 15-year lifespan capacity. And sort of looking back through the various budgets, there hasn't been a major capital upgrade that has happened at the hospital in quite some time. So what's the plans for that? I mean, the last time I was there a couple of years ago, it's dated. It is. But also, I feel like for some of the capital issues that keep coming up, whether it be locks on doors, not working, certain things, the heating and cooling that someone talked about earlier in testimony, that talks to the larger physical plant issues or larger capital projects, like if there needs to be an HVAC upgrade, et cetera. Where are you all in those types of conversations? Oh, you got to turn your mic on.
Yes, Madam Chair. Let me start with the HVAC systems. I'm happy to report, Mr. Tanasia confirm if I overstate. We have partnered with DGS, and that they have recently awarded in the last several, maybe in the last week, a contract to do a major overhaul of our HVAC systems to address the problem that was discussed earlier. It's a multi-million-dollar investment in upgrading the heating and cooling systems with controls by zones in the hospital, patient unit by patient unit, the temperature to represent best practices for HVAC systems. So we have accomplished a very important milestone with regard to upgrading our HVAC systems at St. Elizabeth Hospital.
Well, the milestone
addition-
would be of the start. You just put out the contract.
Yes.
Okay.
So it'll be completed within, do we have a? Yeah, we have a meeting tomorrow morning at 11 o'clock, and I will send you a note after that meeting on progress. When, meaning specifically when we anticipate it to be completed.
Yep.
And I will send you that tomorrow.
I think it also would be helpful to know now when we do major HVAC upgrades in certain buildings,
Yeah.
schools, et cetera, usually nobody's in the building. So I'd be very curious how you all are going to do a major HVAC upgrade when you're a working hospital
Yes.
and what mitigations will take place such that patients and staff are not negatively impacted by particles and et cetera.
Yes.
Okay.
The other, there are a couple of, there's at least one other major project
Okay.
in the planning, and we expect to be awarded in the next 120 days, if not sooner. And that is a replacement of our camera security system. We call it our video surveillance system, which is the positioning over 350 cameras
Yeah.
throughout the facility itself, the building and all the patient units, for example, the medication rooms, et cetera, and the exterior grounds, parking lots, et cetera, to make sure we're all safe And we have video surveillance 24/7 for training purposes, for safety and security, and all of the other features and functions and benefits that come from such a system.
Okay, so I was about to ask a question about coordination with DGS and Octo. It seems like you're working with DGS.
Yep.
Although I'm not gonna lie to you, I did ask the head of DGS as well as their COO, what's their relationship with you guys? And they were like, we clean the snow and like we do the thing. They didn't mention this major HVAC project, which I
Okay.
feel like is kind of a significant thing, but that's something I could talk to DGS about. It seems like you don't really have the ongoing relationship with Octo. You've now decided to contract out for new products,
We do have an ongoing relationship with Octo.
but not for some of the major project needs that we have.
No, but if you mean specifically the VSS system, the video surveillance system?
No. So for the inventory system, the work order system, we're
No.
contracting that all out. We're
Yeah.
not gonna do a project with Octo.
That's probably because they probably don't do that often. Or it's a small project relative to the things that they do normally and are structured, designed, and organized to do. It's probably something that they choose not to get involved with. And
I'm gonna
this is
push
not
back.
something, this sort
The
of
work
thing-
order system for DCPS was Octo in-house. So I'm gonna assume because you're working with OCP, somebody did the calculation to make sure that we're not spending more by going external as opposed to working with our partners in-house. In terms of some of the maintenance requests around locks in particular, how many maintenance staff do you guys have?
Well, let me, before he answers, so locks.
Yeah.
We're hiring a locksmith. So that position has been approved to proceed to hire.
Okay.
And so that's a major step towards the issue we're discussing here.
Did you have a
Locksmith
locksmith
retired.
before?
Oh, yes.
He retired.
Yeah.
He retired.
Yeah.
Okay.
In a high security facility like ours, the locksmith is critically important to safety and systems functioning.
How long has the locksmith position been vacant?
Too long, 6 months or longer.
Okay. All right. A number of the repeated issues reference plumbing. Is that a capability that you all have in-house or do you have to contract out?
We have a professional plumber on staff. He's going, well, I don't want to misspeak, but he has given us reason to believe that he may be retiring in the near future.
Lord, everybody is retiring. What's the pipeline?
No, this is nothing.
Retirement is not a bad thing.
not-
It's not.
nothing.
I'm waiting till I'm there. Okay. You're not gonna have to pull me out of this building. I'm a willingly go.
Yeah.
But I also hope that somebody's being trained. Once someone is giving you notice, hey, I think I'm about to execute on my retirement. Great. Can you stay on a little bit so we can hire someone so that can train you on the functions and the pieces? It doesn't seem like we're doing that part.
Yeah.
There's no requirement that someone gives you notice on retirement, right?
No, they tell us on their own, for whatever reasons they choose to.
Okay.
And we have an excellent plumber, excellent relationship. We've been talking to him. I hope he's listening to
I know.
hear
I'm
us
like, you know,
validate
don't quit
how-
because,
Yeah.
but when I look at the number of
How
things
much
in
we
terms of
think of it.
plumbing, I wonder if he's like, well, dang, how am I unclogging every bathroom on every floor? Can I get some help?
Yeah. Because right now he's very busy assisting with the major construction going on in the transformation of the campus.
Okay,
with
can
the
you,
East
do you guys have the ability to phone a friend? And what I mean by that is you are part of this government. If there was ever a time when you needed help to say to DGS, hi, can you detail us a plumber or two so we can get through our work order? Have you guys done that? I don't even know if DGS has it available. I hate that I'm offering them up, but I'm just trying to figure out what we need to do here so we don't have to go through a procurement process to deal with some of the issues. The document that you all sent us on work orders was
Yep. Yes.
And I'm over my time. I'm not being respectful. Councilmember Parker, thank you for your patience.
No worries. Thank you, Chairperson. By any chance, did we get those rates of overdoses or error prescriptions?
No, we have not, but we will by no later than tomorrow morning.
Is it
If
possible
not
that someone
sooner.
can, is it possible someone can call someone to get the number? I'm really interested, and I think it needs to be on the record, what those rates are. Since part of your testimony is that the testimony we heard is not right.
Yes, so actually I was just looking at PRISM. In fact, we have a adverse medications metric in there that's already available and we publish. Ms. Lawrence, if you will reach out to Dr. Lee, please. And
I
we will
appreciate
work on
that.
it. Yeah.
I appreciate that.
And of course, the information we're sharing with you is confidential, if you would, please.
Yes, I don't want names. I just want stats because I
Okay.
think that's important for the record. Yeah.
Yes.
I wanted to come back to a question Chairperson Henderson had about the medical restraints and the back and forth. It was interesting that the terminology as defined as a medical restraint is anything that I'm paraphrasing, that is outside of what is prescribed for this patient that would involuntarily sedate them, I think is how it was put. We heard testimony earlier that there were 570 patients who were either physically held or locked in a room, and 604 incidents of involuntary injections of medication from January to November of last year. If we think of that 604 number, it seemed like you were taking issue with medical restraint. Are you suggesting then that these are necessary medications for these patients and or they were prescribed?
Yeah, involuntary medicines are a bit different. They go through a different process. When someone has to be overridden, their wishes be overridden, they go through 2 docs, a panel, and then a magistrate. So that's involuntary medication panels. That's not chemical restraint. It's when someone requires treatment and they're being imminently at risk. Those are the standards.
But would you agree with those numbers that roughly it was 604 incidents of that involuntary injection between January and November of last year?
I wouldn't want to comment on the specific number. I mean, we track these very carefully. So if we've generated that number, that's fine. But I don't have it in front of me to tell you that you have exactly the right one.
And so walk me through. So, and what I'm trying to get at is you took issue with the term medical restraint.
Chemical restraint, council member.
Or chemical.
Yeah.
Okay. I'm sorry.
Yeah. So chemical restraint is the term. It has a specific definition and it's no longer used. We all know not to use medicines as restraints. So it's not medical restraint. Okay. So involuntary medicine is something different. This is chemical restraint. It's an old form of controlling people, and it's not done.
And so of these 604 incidents, though, would you agree that at times they are meant to sedate the patient against the patient's will?
No, it's treatment over objection is what it is. It is not sedation.
So you're saying never in those involuntary injections would the patient be sedated?
No, I'm not saying that. The medicines can be sedating, but this is treatment over objection. It's not chemical restraint. A restraint is something urgent, imminent. It happens right there because someone's going to hurt someone or hurt themselves. Involuntary medicine is treatment over objection.
And treatment over objection. And that treatment, I'm assuming, is prescribed, which inherently is subjective. And what I'm getting at is, let's say this number is accurate that we heard in our testimony. 604 incidents of treatment over objection, at times resulting in sedation. Were there other options available for that treatment? And what the testimony was getting at is that we should be moving away from these involuntary injections that sedate patients. And I would agree with.
Not my reading of it. And again, knowing disability rights very well, having been in public sector for 30 years, I can assure you that's not exactly what they mean. Everyone wants to decrease, diminish restraint and seclusion, but not treatment. The problem is that some people are incompetent.
Okay, I guess they invited you here to talk in legal speak. I'm very clear what I heard. What I heard in the testimony was that people are being prescribed medication, given medication against their will, that at times or often results in sedation. Now, we're talking semantics and past each other, and you're saying, well, medical restraint and chemical restraint is different. The headline is people are being given something that renders them sedated. And the testimony I heard very clearly is that we ought not do that. And I agree with that. And the question I'm getting at, beyond the semantics, is what steps is the team taking to reduce the 604 incidents of involuntary injections? And just a tangent, I hear what you're saying. Maybe these are injections are being prescribed, quote unquote, but I'm assuming that is one of several options. So again, what steps are being taken to reduce those incidents?
Sure. So there are plenty of options, psychological options, behavioral options, counseling, support, the kinds of things that you heard earlier. Someone might like music or taking a walk. All these interventions are positive behavioral support. It's part of what that team does. It's part of what the multidisciplinary team does. And again, you're not supposed to head for the emergency intervention unless other things have been tried. So I assure you that's exactly what's been done, and that's what has to be documented whenever something like this happens. So something else has to be tried.
Okay, that's good to know. So your testimony is for every incident of involuntary injection, there will be proof or record of another less extensive option being provided first.
Right. And can I say that the involuntary medication also goes through these multiple steps of review? So it's not just that someone is haphazardly treating someone, it's that it goes through 2 docs, an involuntary medication panel, and a magistrate. So all of this is protective of treatment. It's protective of the patient. And again, I'm not a lawyer, but I can tell you that there are policy differences in public sector between these three things. That's why we define them differently, so that we don't say that we are chemically restraining people. We don't do that.
I hear you. Dr. Basron, I wanted to come to you. We heard testimony that St. Elizabeth's contracted with a national expert with the goal of bringing down these levels of restraint or seclusion or involuntary injections, whatever term we want to use. In your testimony, you referred to this contract as patient-centered, recovery-oriented, trauma-informed care. We've also heard testimony that maybe this contract and provider is not being utilized optimally. I'll put it that way. Can you share more about the contract, when it started, and what sort of progress has been made with respect to a reduction in these restraints or sedations?
Yes, certainly. Thank you for that question. Actually, the contractor is the National Association of State Mental Health Program Directors, and Dr. Joan Galise is the project lead. She is an expert in trauma-informed care, and she has developed an effort. It's called the TAMAR program. And what it does is it really looks at how do you change what's going on in the environment to reduce violent behavior and assaultive behavior within the milieu. So she works with not only the staff, but also with people in care.
And then very quickly, I have 20 seconds. When did the contract start? How long will it run?
It was several years ago. I'm trying to remember that I had that contract started. It is still in place and will still continue. And by the way, ULS has been extremely supportive of that contract. And we meet on a routine basis with Dr. Galise so that she can give us the results of what's happening and in terms of the intervention that her team is doing.
Understood. That is my time. Thank you, Chairperson Henderson.
Thank you. We've been joined by Councilmember Crawford online.
Thank you, Chairperson Henderson. Can you hear me okay?
Yes, I can.
Okay. Hi, Dr. Basron and team. Forgive me if some of these questions are repetitive. I had meetings in between when I was at the hearing earlier. So DBH stated in its pre-roundtable responses that after a violent incident, the hospital immediately offers medical, emotional, and practical support to staff. However, we heard from staff today that DBH provides no support to hospital staff when violent incidents occur. What is your response to this and to those witnesses?
In the beginning, when we were having, okay, we do have a program called Support Our Staff. It is just the remnants of what we used to have. And it would be if an individual was injured during a violent episode and they needed to go to the hospital, we would go with them. Somebody would go with them and stay with them until the family member arrived. Some of the folks did in fact follow up with the employee at a later time. That program actually decreased its activity, and we are now in the process of trying to re-implement it and to expand it. So it's not just dealing with the staff when they've been injured during a violent episode, but also to provide them support when there's something has happened within their family, or when there's something has happened on the unit with a patient that they've taken care of for so long, to give them support and help them work through. We also,
if I could interrupt, does the severity of the incident, for example, if a staff member has been hospitalized, determine whether you provide support to the staff?
no, that does not make a difference. If a person has to leave the hospital for triage or whatever, we try to have an individual go with them. But that pulls from the rest of the staff. Some of our folks have been, some of our staff have actually been trained in medical emergencies, psychiatric emergencies, and they will go. But as I said, we're now looking to implement it or re-implement. We're working with one of the folks out of PBS so that we can deal with more than just the violent episodes that occur, but to deal with the trauma that they're feeling. And that's in progress right now.
I see a lot of also visible reactions in the room. So I just want to ask, can you commit to ensuring that staff receive comprehensive support after all violent incidents, even if those incidents do not result in hospitalization?
I'd like to really step in, Councilmember Crawford, and say that I'm really sorry that staff do not feel supported, and I am committing to ensuring that staff get the support that they need when these incidents occur, because that should happen.
And will you also incorporate their feedback as well?
Pardon me?
Will you also incorporate their feedback as well as part of that?
Absolutely, absolutely.
Yes.
Okay, thank you. Additionally, in DBH's oversight responses, the agency stated St. Elizabeth's does not mandate overtime and double shifts. Mandatory overtime is implemented during emergencies such as inclement weather in compliance with collective bargaining agreements. Again, what we heard today is that employees feel compelled to stay at work due to staffing shortages and inconsistent and often late scheduling. What is DBH's response to this, and can you commit to more timely and transparent scheduling?
So we do not, as a general matter, mandate overtime. Again, as I mentioned earlier, when we have a inclement weather emergency, as is forecast in the next 48 hours, our first step is to ask for volunteers. And out of a sense of duty, without fail, we have had staff volunteer. We do not consider that mandating that they do so. We're very thankful and proud that they volunteer.
So how do you respond to, we heard this morning from witnesses who said they feel like they cannot leave?
There are very infrequent situations in every hospital in the country that someone is late. There is an unexpected call off by staff on a unit that's unexpected, and it puts everyone in a difficult situation. And some staff may have to stay over until someone comes on board to relieve the shift that's leaving. That does happen. We try to do what we can, deal with the individuals who suddenly called off, and individuals in particular who do this as a pattern in their attendance behavior, to deal with that so that it doesn't happen in the future. So we take it very seriously. It's very disruptive and inconvenient. And so that's how we deal with it and commit to do so more rigorously going forward.
Do people get penalized if they do decide to leave?
It depends on the circumstance. In general, no.
Okay, and then again, can you commit to more timely scheduling? Is that possible at this time?
We'll commit to whatever's within our control to address the issue. We heard it as well, and we will look at that. We'll look at it as at our next shared governance meeting. Where such,
When is your next shared governance meeting?
within the next 2 weeks. Does anyone know offhand? Just a second, I can tell you.
Okay.
This is where we meet with labor and we talk about all these kinds of issues.
Okay. If you could share that with me when you have it, I would love to follow up after that meeting.
February 19th.
Okay, thank you. And then according to the St. Elizabeth's Hospital FY24 staff survey results, the majority of staff do not feel supported by executive leadership and agree that staff do not discuss how to prevent errors from happening again. What steps have the hospital taken since these survey results were released to improve leadership accountability and ensure staff are routinely engaged in identifying and preventing repeat errors?
Councilmember Crawford, I'd like to respond to that. Deputy Mayor Turnage and I will be meeting on site at the hospital on every 3 weeks to really not only identify and address these identified issues, but track progress. And I think that, that way we can see what the changes are and how we can move forward.
Thank you. Well, my team and I will also follow up on that because I'd like to hear how that goes. Shifting gears a little bit on DHS's emergency demolition, do you anticipate that the emergency demolition will impact the operations or quality of care at St. Elizabeth's?
Are you referring to the campus construction?
Yes.
Yeah, no, I do not. Well, it will have some impact on staff coming to and from the hospital, reporting for shift, because there's road work, extensive road work to the entrance of the hospital campus and parking area. So yes, for some period of time, it will have an impact. But we have meetings, at all hands meetings. We go over these issues. We show pictures of the construction. We talk about the impact, when it's going to happen, how it's going to happen, and our staff see it every day when they come and go. So yes, it will have some impact.
Have they already, before you continue, have they already expressed any major concerns? Your staff?
Not major concerns, but the sort of natural concerns of coming and going in traffic. Some reports of running over nails, which happened to me one time as well. That's real. That, you know, flatten your tire, rocks kicked up. So we respond to those on occasions when they are reported to us.
Okay, thank you. I'll yield the rest of my 15 seconds back to the chairperson Henderson.
Oh my gosh, she's so timely, so polite. Thank you, Councilmember Crawford. Did you have any other questions? Because I'm gonna ask
No,
some questions
I
and we're gonna wind this down. Dr. Basron, let me ask, does St. Elizabeth's Hospital in its current configuration, not in its past, but in its current modern day time, did it ever have a board?
No, there has not been a board of directors of St. Elizabeth's Hospital like there are for acute care, most of the acute care hospitals.
Right, but I also know that in some other jurisdictions, their state institutions also have like a board of visitors, a board of advisors.
Some do. When I was in New Jersey, I mean, not in New Jersey, I'm sorry. When I was in Maryland, there were boards of advisors for some of my hospitals, not for all of them.
Right.
When I was there, but not a formal board of directors in place.
Okay, I'll come back to that in a different. So there are just a couple other things I want to follow up on. We already talked about CPAP, so I got that sort of clarification, and I look forward to discussing further with you. I know that you guys have different opinions in terms of public testimony that was presented. There was some public testimony that was presented today that had some allegations, some of it beyond my control. Allegations of Medicaid fraud, we're going to send that to the Inspector General and sort of let him look further into that. Allegations around plagiarizing provider notes, we're going to refer that to DC Health because that's the place for that piece. And I think this is I do want to follow up on this part though, in terms of pharmacies within the network. So not just St. Elizabeth's, but 35 K Street and CPAP, the pharmacies, having individuals who are practicing under a retired license. Do you want to speak to that, Dr. Basron?
I don't know of anyone practicing under a retired license. At CPAP, we had a contract pharmacist that was fully licensed who was working there. And also at St. Elizabeth's, we have a licensed pharmacist who's working there.
Okay.
And at CPAP, CPAP is kind of a subsidiary of St. Elizabeth's, and so I'm not quite sure about the person there.
Okay, this is what I would say, and this is for the public witnesses who are here and the public witnesses who might be listening or interested parties. There are regulatory and governance pieces amongst every part of this government. And when there is a complaint about something specific in terms of the professional, I don't want people to think that your only avenue for complaint is within the organization for which you are. Because when I asked DC Health about complaints that they have received regarding particular incidents, and this is not just for staff, but I've had the same conversation with disability rights and others. If you don't report it, they cannot investigate it. And so, you know, when I asked DC Health about, did you hear about this? They're like, no, we didn't hear about that. Or did you hear about this? No, they didn't hear about that. It doesn't, if you may feel like you're following the chain of command to just tell your supervisor and hope for the best. Sometimes you just have to use the regulatory pieces that are available to you, whether it be the Board of Nursing, the Board of Pharmacy, the Board of Psychology. They all exist. They all hear complaints, and there are all processes for that. But it makes it really difficult for us to investigate whether or not something is occurring or not when it's not reported and we only hear about it in a public hearing setting. So I would say that. I do want to ask about the question around housing. Now, Dr. Basron, we've had this conversation before, but it is deeply concerning. The idea that there are people who are at St. Elizabeth's Hospital who don't need that level of care, or maybe that is not the appropriate setting for them, whether it be if it's somebody who's on the geriatric unit, maybe you don't need to be there. Maybe you need to be in memory care, and that would be a better, but there might not be a place for you, or like, who's responsible for that type of coordination? If there is a recommendation made that this is actually not the least this is not the best and least restrictive setting for someone to receive their care.
I can share with you that one of the major concerns and issues we have is we have people at St. Elizabeth's Hospital who need nursing home care. And when applications are sent, they are rejected because of their psychiatric disability. DHCF and I, the Medicaid director, and I have been working with the nursing home association and leadership to see if there's any way that we can address that issue. That is a major problem. The one thing that we have been doing within our purview is we have been providing through one of our nurses some training at the nursing homes around things like substance use disorders and mental health issues, hoping that that will open the door a little bit.
But I imagine
we have a number of people who are there.
How many are we talking about?
How many? It
Is 15.
15 to
20.
17.
Okay.
People.
This is not an issue that is unique to us. I know it's not.
Huge, yeah.
I'm sure it is a huge problem across the board. Heck, it's a problem across the pond, if you will. I was reading an article on BBC a couple of weeks ago, and they were talking about the number of individuals who are within their national health NHS who are at a hospital, who don't need to be at a hospital, but there's no place to safely discharge them to. So everybody is sort of facing this, but I don't think our response can just be, well, you're just going to hang out at St. E's until we figure it out. We have to figure out what is our concerted plan. Perhaps there's a regional response to this, because if Maryland and Virginia are having the same problem, maybe this is an opportunity for us to do something unique in terms of, all right, let's put our resources together to try to sort of resolve this issue. But even having 15 to 20 people, that's 15 to 20 other people who are either on your wait list, because I think you said that you guys have a wait list every day of 20 or so individuals. But it also might just sort of help in terms of their ongoing care. It is, I said this earlier, but it doesn't sound like a hospital that you're running. And I know that the population is forensic, but it's still a hospital at the end of the day. And so we have to figure that out. Before I wrap, I want to call back up Mr. Reed to see if he got the info. Okay. All right. If you want to switch out. All right.
Hi, so I do want to provide an explanation just for transparency for everyone who's listening in. The total supply budget for St. Elizabeth was 4.7 million. Comprised of that were two different buckets of funds. One bucket is guaranteed funds, 2.1 million, and the other bucket is revenue-based funds of 2.6 million. Of the revenue-based funds, there is $1.6 million that's showing available, but it's not in the available revenue because the actual revenue did not come in. So the budget will show that there is a total available, but there's a difference, as you know, between budget and revenue. Budget is the amount that we set to allow you to spend based off of what we anticipate. But the revenue that came in was $1.6 million less. So if anyone sees that budget book without context, they'll think that there's $1.6 million that was available to spend that has not been spent, and that's not true. The $1.6 million is showing available because the funding was actually used in overtime and salaries before it was spent on supplies.
Okay. There's so much to unpack there. Can you say that last line one more time?
Yes, the $1.6 million that will show available when you review the budget book
Yeah.
will show that it's available, but it's actually being used in a category of salaries and overtime before it could be used on supplies.
Okay. Is it normal practice for the supply line to be split between guaranteed and then revenue based?
Yes, that is normal practice for any budget line that an organization may have.
Okay.
And we can look internally to prioritize what would be funded with revenue-based funds or guaranteed funds. So the agency can do that internally, but that is a normal practice based off of what I've seen in DC government and other organizations that I've worked in.
Okay. I just kind of feel like, toilet paper should be guaranteed, not based on whether or not the revenue came in. But, we'll dig into that more in terms of budget. But thank you for this clarification, because I think this is super helpful. But I think it also kind of it answers some questions of like what you see in the budget book may not fully reflect
Exactly.
the whole story. So I appreciate you providing that context.
And may I add additional context about the freezing of positions?
Sure.
Because I wasn't in that meeting. I think since I wasn't there, I think the explanation is, the approach is everything at DBH is frozen right now. However, Dr. Basron has continued to say that St. Elizabeth's is a priority to her. So she implemented a process that was not implemented in FY25 at the agency level. All positions have to be presented to her so that they can be sent forward, and she can quantify the total of the request to determine what she was going to reduce in one area of the agency to prioritize St. Elizabeth's. So the end result, they're not frozen. I think when people hear frozen, they're thinking about a process that is not the same as it was in previous years.
Okay. But the question was whether or not those positions were available for hire.
They are. They are. And
Right.
so they're
I
not
was
frozen.
told that they were not available, and that is why they were vacant. So
I hear you. I just wanted to make sure
yeah.
Since I wasn't there in the meeting, I wanted to provide context that there's an additional process, but that process doesn't mean that the positions are not available. Dr. Basron is just trying to be fiscally sound, and I'm supporting her in that.
I appreciate that. All right. Well, thank you for that clarification, Mr. Reed. This has been a very illuminating hearing. I'm actually glad that several of my colleagues did join to sort of hear in, and we can all in some ways share in some of this. This does conclude our roundtable right now for right now. I want to thank everyone who participated today, who shared their experience and their expertise. I believe your perspectives are critical as the committee evaluates the current state, again, of the district's only public psychiatric hospital. I think what we heard today underscores both the urgency and complexity of the issues and the challenges that the institution are facing, whether it be staffing, workplace safety, dealing with facility conditions, operational accountability, et cetera. And, while there are some policies and procedures that are in place, I think what we heard today is that we need consistent implementation. We need some transparency, certainly follow through, because words are a lot, but without action, they mean nothing. To restore some confidence here, I also want to encourage the leadership of the hospital, phone a friend on some of these work orders. DGS has multiple not to exceed contracts with contractors out there who can assist in sort of a blitz manner, come in, help you get some of this stuff done. And I'm sure DGS, we could figure it out, but they don't know unless you're sharing that information or unless you're asking for that particular help. Written testimony is going to be accepted through Thursday, February 5th, 2026 at 5 p.m. through the council's hearing management system site. If you haven't submitted your written testimony for the record, please do so. The next hearing for this committee will be on, it is currently scheduled for Tuesday at 11:30. We'll see what the weather allows. We're gonna have our first performance oversight hearing, which will be for the Deputy Mayor for Health and Human Services, and the Deputy Mayor for Healthcare Finance. For the purposes of this, Dr. Basron, I'll see you in February for a performance oversight hearing. I think the government witnesses for DBH is on February 4th. So we'll follow up on some of the issues here that were discussed, but obviously talk about all the various issues related to the Department of Behavioral Health. Thank you all for being here today. The time is 2:54 p.m. and this hearing is adjourned.